in Southern California since 2012. As part of the commission, Dr. Merino is responsible for the development of a functional strategy for the county's mental health and the vision behind that strategy. She helps to establish the district's direction and focus, execute multiple high-impact initiatives to achieve overall county goals, and provide mental health oversight to 500,000 residents. She is the founder of Black Women Congress and African Mental Alliance, whose goal is to empower members of the community in the areas of spiritual, educational, professional, and physical wellness. The Black Women Congress is a strength-based initiative for women and girls of color to achieve economic and emotional justice, while the AMHA is Africa's leading mental health alliance dedicated to addressing advocacy, research, prevention, treatment of mental illness, and to promoting the overall mental health of all Africans. She works with both national and international bodies, including governments, to formulate and implement mental health systems. This morning, please welcome with me Professor Akindotu Merino.
Thank you. Thank you for that introduction. We really appreciate you. Welcome, everyone. I am so excited to be here, and with all of the speakers in the house, all the presenters, we have commissioners, we have heads of departments, we have chairs of organizations here. We know that this is the beginning of great things in mental health space. We know we've been doing a lot in this space before, but today we start to come together. So we've brought together coaches, we've brought together psychiatrists, we've brought together psychologists, we've brought together ministers. They're all here today, and people who just want to be here because they want to hear what everybody has to say. So welcome, everyone. It's going to be a really dynamic presentation. So please don't be in a rush. Get your cup of tea, get your coffee, anything that you want that's going to make you stay here for at least 3 hours. And we have a lot to say. And we're coming back again tomorrow. For those who are coming back tomorrow will be the speakers who are interested in formulating, in moving forward with the Alliance. But before we start, we need to start with an opening prayer. And we have Reverend Austin here, who is going to lead us in opening prayer. We need to unmute him. Dr. Austin, please unmute yourself. Okay.
There you go. Can you hear me now? Hello, can you hear me now?
We can hear you. Please go ahead.
Okay. Let's pray as we start this morning. Our Heavenly Father, we are thankful to you for a day like this, opportunity for all of us to come together to discuss the well-being of the many human beings that you have blessed our nation with, and how we can help them grow in one aspect of their humanity and be healthier in terms of their mind. We pray, Lord, for every speaker, everyone that will have the opportunity to share with us. And Lord, you will grant them grace to be clear. You will grant us all understanding. And Father, in our deliberations together, we can hear each other well enough and be able to understand each other well enough that we may be able to forge ways ahead that will be a blessing to each one of us personally, but to all of the people of our nation, in terms of the growth of the people of this nation, the development of the people of this nation. Lord, make this a consequential gathering that will transform and impact this nation by your grace. Thank you for everybody that is able to be part of it. Let them have, let this experience be a pivotal one, a memorable one, and an impactful one for everybody. We ask this in Jesus' name. Amen. Professor Meriho, back to you.
Thank you very much, Dr. Austin. Good morning, good
Amen.
afternoon, good evening from where
Thank you so much for that. And we are going to welcome our moderators. We're going to welcome Tolushe, who is doing great work in the mental health space, and Bingpe, who is our director of communications and everything else. We welcome her. They're both going to moderate. Thank you so much. Tolushe Francis. We will introduce him later because he's also one of the presenters.
Thank you very much, Doctor, for the introduction. I don't know why my video has refused to start, so I don't know how you're going to see my face.
Tolushe, if we have your video on, we can spotlight you.
Yeah, I don't know why my system is refusing to start my video. I don't know what I've done this morning to deserve this. It was working.
I can't hear you either.
Oh, can you hear me now?
Just a little bit.
Okay, so I said I don't know why my video isn't coming on. It was coming on before now, but for some reason it's refusing to come on. But
okay.
Yeah. So let me just get started. I'm going to fix it when Prof is talking. So good morning, good afternoon, good evening, wherever you're joining us from. My name is Tolushe Francis, and we'll start this morning by having Professor Taiwo Lateef Sheikh. He is the President, Association of Psychiatrists in Nigeria. I'm just going to read brief. Now I say brief because he's a man of many parts and so much qualification. I mean, going by that standard. So we'll just try to summarize his profile. Taiwo Lateef Sheikh, MBBS, MSc, Fellow West African College of Physicians, is a professor of psychiatry at the Department of Psychiatry, College of Medical Sciences, Ahmadu Bello University, Zaria, Nigeria. He is an alumni and faculty member at Harvard Global Mental Health course, Harvard Program on Refugee Trauma Master Certificate. He obtained an MBBS degree from the Medical School of the Ahmadu Bello University, ABU, Zaria, Nigeria, in 1985, and an MSc in Clinical Pharmacology from the same university in 1992. He is a fellow of the West African College of Physicians, a faculty member and examiner at Faculty of Psychiatry, West African College of Physicians, and an external examiner at Ghana College of Physicians and Surgeons. He is currently the National Secretary, Nigeria, West African College of Physicians, President of Biological Psychiatry Society of Nigeria, President of Association of Psychiatrists Nigeria, President Psychological Relief Society of Nigeria, an NGO, and the Chairman of Psychotrauma Working Group of the Association of Psychiatrists in Nigeria. Currently, Prof is engaged in the training and supervision of undergraduate and postgraduate students and resident doctors in the field of mental health. He is a member of the National Action Committee on Mental Health in Nigeria, where he participated in the development of mental health policy for Nigeria in 2013. He led the integration of mental health into primary healthcare delivery service in Kaduna State, Nigeria. He is presently a member of the committee working on the Nigerian mental health legislation, the mental health bill currently before the National Assembly, that is currently in the process of being passed into law by the Nigerian National Assembly. Professor Sheikh is actively involved in mental health policy decisions in Nigeria, training of mental health professionals, as well as mentoring young mental health professionals in research and career development across West Africa's sub-region. Ladies and gentlemen, we have with us a scholar, a man of many parts, a man who has traveled far and wide. He will be speaking to us today on the topic, what are the public policy responses to the mental health impact that are most likely to deliver real benefits? Please, wherever you are, join me to welcome Professor Taiwo Lateef Sheikh. Over to you, sir.
Good morning. Thank you very much. Humbled. Can I share my screen, please?
Okay, so let me just give you that permission.
While doing that, I want to thank the organizers for inviting me to talk here. I want to recognize the honorable commissioners that are present on this platform. I want to also recognize eminent personalities, medical directors, former provost and medical director of Federal Neuropsychiatric Hospital, Abeokuta, Aru Abeokuta. I could see his name, and all other dignitaries that are here. I recognize your presence, my colleagues. I also recognize your presence. So thank you very much. Can I go ahead and share this now?
Please go ahead, sir.
Thank you. It's just a few slides. To start with, I was actually asked to, can you see my slide?
Yes, we can.
Okay, so I'm supposed to talk about what are the policy responses to mental health impacts that are most likely to deliver real benefits. The time is quite short. I was asked to come and deliver a talk on this in this symposium by the Honorable Commissioner for Health, Kaduna State. She asked me to share with this group what we're doing for Kaduna State in terms of implementation of policy. However, when the topic came, it appeared to be a little bit beyond that. So I cannot deliver completely what we do for Kaduna State, but I'll just give within the next 10, 12 minutes an overview of how public policy can affect mental health service delivery in our country and particularly in Kaduna State. So this is my outline. I will introduce the topic. I will talk about the drivers of mental health policy. I will talk about mental health systems in Nigeria. Then I will briefly talk about national mental health policy national policy for mental health services in Nigeria, and then our parting word. So I always take delight in quoting this speech by the, Director General of WHO, Dr. Tedros Ghebreyesus. He said that the world is accepting the concept of universal health coverage. Mental health must be an integral part of universal health coverage. Nobody should be denied access to mental health care because he or she is poor or lives in a remote place. So you can understand what this means, which means mental health care should be universally accessible, affordable, and available for people. He went on to say that mental health conditions contribute to poor health outcomes. And we all do understand this because mental health is part and parcel of every health condition. It also contributes to premature death, human rights violations, and global and national economic loss. The time to act is now to empower communities and individuals to attain highest standard of health, which can only be achieved when their mental health and well-being is ensured and their rights respected. The vision of the WHO Special Initiative for Mental Health is that all people achieve the highest standard of mental health and well-being. As we all know, that mental well-being is not a mere absence of mental illness. We all know the definition of what mental well-being is. So when we talk about mental health policy, what are actually the drivers of mental health policy? In order to answer this question, I would like to take you through the mental health system in Nigeria. And I want to start with health financing. We know that Nigeria, majority, in fact, virtually everywhere, ours is a traditional out-of-pocket health finances. There is lack of equity and there is limited healthcare delivery. The cost of care is prohibitive due to direct and indirect or incidental expenses. We know we have Nigeria Health Insurance Scheme, which became operational in 2005, with an overall objectives to ensure that all have access to healthcare services. But today, we do know that healthcare insurance is available to only very few people, probably less than 5% of the Nigerian population. I must say here that Kaduna State is actually rolling out its own state insurance policy, which we believe will bridge this gap. The mental health in Nigeria is mostly concentrated in the federally owned tertiary hospitals, the 8 federal neuropsychiatric hospitals and the teaching hospitals that we do have. Most of these facilities are located in state capitals. They are out of reach of majority of patients in need. Standalone facilities are associated with stigma. People look right, left, and center before they can enter such facilities. Mental health declared the 9th component of primary health care sometime in 1991, and is supposed to be part of primary health care services, but today it is totally absent. So I'm talking about the drivers to policy. What are the things that drive policy in terms of mental health? If we look at the human resources, we have less than 300 psychiatrists in Nigeria, and most of these are located in state capitals. Similar statistics go for psychologists, trained psychiatric nurses are given other responsibilities in the state hospitals or wherever they are practicing because of lack of political will to offer mental health services by the institutions and the government. In terms of mental health legislation and policy, there is no existing national mental health legislation. What we have today is the Lunacy Act, which we inherited from our colonial masters, and it was actually a 1914 law that we are still operating in Nigeria today. So we have a mental health bill that is before the National Assembly. It has gone through the Senate reading. It's at the National Federal House of Reps, awaiting concurrence before it goes to the national, president for accent. Our mental health policy, the mental health policy document of 1991, which we developed 31 years after independence, was revised in 2013. And it is the 2013 revision that we are using. And this 2013 revision, which I am lucky to be one of the people who did it, has a placement of vision of mental health services at the primary health care level through task shifting. Mental health services continue to toil under the legacy of colonial mental health systems, with heavy reliance on standalone federal psychiatric hospitals. No parity in resources for mental health and physical health alike. There is limited mental health promotion and prevention activities in Nigeria, and there is lack of accurate, routinely collected data regarding mental health service provision in this country. So that now brings us to the National Policy for Mental Health Service Delivery of 2013, which actually is good enough for revision by now. What that policy captures adequately is what I've quoted here, that good quality community-based services with hospital support has been shown to be the most effective form of comprehensive mental health care. The Federal Ministry of Health is committed to the provision of evidence-based care through the expansion of accessible, decentralized services in Nigeria, which will address the mental health access gap that currently exists in this country. I want us to understand at this point that when we talk about policy, policy is not a law. Policy is only a commitment, a promise that is quite subjective, that is based on so many other ifs and when and who and so on, that the government will make to its own people that will be able to do this. It is not a law. Government is not in any way can be compelled to implement a policy as it has stated. However, by the time we have a legislation will now compel government to implement its policy. So presently we have this policy of 2013, and this is from what I'm quoting is from that policy. The vision of the policy is that the government and the people of Nigeria hereby reaffirm that health, including mental health, mental well-being, is the inalienable right of every Nigerian, and that mental, neurological, and substance abuse care shall be made available to all citizens within the national health system at the level of primary health care and in communities. So we could hear the primary health care keep recurring, which means that the policy of mental health care delivery services in Nigeria is actually hinged on integrating mental health into primary care services and the communities. So, to provide adequate mental and neurological care for Nigerians, the following major areas of reforms are to be effected by the Ministry of Health. Number one, mainstreaming mental health and neurological health within the national health, social welfare, education, and criminal justice policy. Integrating mental and neurological health into the primary care system. Strengthening and developing existing systems for human resource development, information, and communication. Decentralization of specialist mental and neurological health services. Strengthening management of mental and neurological health services. Encouraging intersectoral partnerships with other key government organizations and non-government organizations. Finally, linking to educational programs in schools, workplaces, community, and the media. So this is key to integrating mental health into all levels of healthcare delivery services in this country. So I have my parting word, which I've just given you, raise your appetite, something to be discussed in terms of mental health policy for Nigeria. So my parting word still remains that nobody should be denied access to mental health care because she or he is poor or lives in a remote place. So I thank you very much for listening to me. Thank you.
Thank you very much. That was a very beautiful one. Like he said, he has just given us a tip of the iceberg. When professors create documents like these, you know that it's usually very detailed, but he has tried to just give us something to whet our appetite and to run along with. So thank you very much, sir. We move on to our next speaker. He is the managing director of Post Factory, a West African partner to 6 Seconds Emotional Intelligence Network USA. He is also the co-founder of Global Search and Strategy, Nigeria's delivery partner to the KPI Institute Australia, and the founder of Simeon's Pivot Resources, a leading human resource and management consulting firm whose focus is on performance improvement. He presently serves as the president of the Life Coaches Association of Nigeria. He sustains an unwavering commitment to magnifying man's limited efforts in today's workplace, business, and life. His major goal is to help individuals and organizations get the most out of themselves and help them get to their destination irrespective of where they are. He consistently achieves this goal through life/business coaching, training, and organizational restructuring, strategic planning, change management, scenario planning, and other human resource solutions. Ladies and gentlemen, speaking with us today on the topic, the role of Nigerian life coaches in the mental health space, is the President, Life Coaches Association of Nigeria, Mr. Enahoro Ohai. Thank you very much for joining us, sir. Over to you.
All right, muted now. Good morning, everyone. Excited to be here. Thank you, Prof, for that wonderful beginning of this conference. I think that this is very, very, very important, extremely important. And thank you to the organizers for making this happen. This should be the kind of discussion that we should have continuously, every day, because it is very, very important. So thank you to the organizers, and permit me to leverage on all the existing protocols. I appreciate everyone that has been invited here and that is here. We have our colleagues from the association here too. Thank you all for showing up. The role of coaching, the role of life coaches in mental health in Nigeria has become a very, very, very crucial part of the discussion. Before this type of gathering, there is always going to be questions like what the coaches do, what the life coaches do. Are they therapists? Are they, what do they have? How do they help in all that we do? That is the real importance of this gathering. And I'm going to say it again, This is just the beginning. It should not end. Every time I sit down and I think about the issues concerning mental health, one thing is common. There's a man out there that needs help. Whether he needs the help from a coach, or he needs the help from a psychiatrist, or he needs the help from a neurologist, or he needs the help from any mental health practitioner, the common factor is that this person needs help. A coach, a life coach, as defined in several definitions out there, is somebody who partners, is about partnering with someone in way, the creative process that inspires the person to maximize their own potential. Coaching is a holistic orientation to work with people, to help people find balance, find meaning, find their own enjoyment so as to improve their skills, improve their effectiveness, improve something about them in order to achieve the goal. Now, when it comes to the relationship between coaches and other practitioners in the mental health industry, mental health field, there is particularly a few things that coaches will do or must do. You know, looking at the environment today in Nigeria, for someone like me and a lot of coaches, we receive a lot of calls from the average Nigerian who is depressed, who have one anxiety disorder or different types of disorder here and there. When the average man calls for help, he doesn't know what they really want. They don't know. Sometimes they call and say, am I speaking to a therapist? Sometimes they call and say, am I speaking to a coach? Sometimes they call and they say, all they say is that I just need to talk to someone. Now, the certificate
I think we look.
Okay, I'm trying to be sure. Is it from my end or is it from his end?
I think it is network.
While we wait for him to come back, I think network is dealing with him.
Okay.
He's been logged out. Okay, I'm sure we learned quite a lot from the previous speaker, that's Professor. Just a minute.
So I think let's give him let's give him a minute or so and see if he'll come back. And if not, we'll go to the next person.
Yes.
So Lucia, I can't really hear you, but I think I can figure out what you said.
Yes, I said we'll just hold on a bit to see if he gets in
Okay, excellent.
quick enough. Yes,
Absolutely.
just hold on a bit. So while we are there, I see some of us asking for Prof's slides. So I guess Dr. Merino would work on getting that across to us. I think it's a document that we all would love to read, as it kind of shows what a particular state and what people like him have been working on before now. Okay, yeah, now he's trying to come back in. Okay.
Prof, Seek, if you can forward your PowerPoint or drop it on the chat room, or forward it to me, we can share it, or you can just drop it in the chat room, please.
All right. Now he's trying
I think that would work.
All right. Welcome back. So get started.
Can you hear me? I've had to switch from my system to my phone using different internet. Can you hear me?
Clear.
Can you hear me? Hello?
We can hear you loud and clear.
You can hear me. Okay, great, interesting. So apologies for that. I'm moving between one service provider or the other. Okay, so I was saying that when the average Nigerian needs help, they're really not sure who to go and meet. Now, the work of a life coach is to partner with them. And there are a few differences between the life coach and several other practitioners. And a few differences, if I would list, would be that when the life coach is relating with someone, we relate to them not from the place of seeking to remove pain from them, but to empower them. So a life coach would usually focus on the future. A lot of therapists would focus on the past, what has happened to you in the past. A life coach would invite a client, to take an effective action to solve a challenge that they are having. Rather than a passive approach and a reflective approach. A life coach would ask questions: what is possible? What do you want to do now? What can be done? Rather than what is the problem? Now, the role of a coach particularly would be to be able to identify how to help a client. And in that how, it will be to determine if this client sustains a challenge that a coach can satisfy, that coaching can help, or would have to refer. So if you talk to the average certified life coach, they've been trained to know when to refer a client to another practitioner in the mental health space. So if we receive a call and somebody is talking about a challenge that is interfering with their day-to-day functioning, or if I'm working with a client as a life coach and I can see that the client is not making progress, maybe the client is having emotional challenges, they're not happy, but after 1 week of working with the client is not making progress. If I find someone who is depressed, who has eating disorders, who is struggling with substance abuse, post-traumatic stress disorder, suicidal ideation, thought disorders, what we do as life coaches would be to then refer the person to who would help the person. I must confess that we most likely would receive the call before a psychiatrist would. The average early 20s, late teenage age today know how to pick the call. Go to Google, get a phone number, pick the call, and most likely that call will end up on the phone of a life coach. But the life coach has been trained to know that this person needs to see a psychiatrist. Now, so there is the pre-mental health illness management, and there is the post. So a life coach is very important in the pre to help the person identify that you need to see a psychiatrist, you need to see a psychologist. And after the illness has been managed, a life coach is very important to help the person move forward in life. So to set goals and say, yes, so you've been able to manage substance abuse because you've gone to rehabilitation, but how do you sustain this going forward? What goals do you want to set? Now, a life coach would partner with that person and help the person to tap into their strength within them and help them to achieve that goal going forward, rather than, and so that will help the person most likely not to get into relapse. So pre-mental health illness management and post-mental health illness management, the place of life coaching becomes very, very important. Now, this is important. I want to speak to everybody that is listening in whatever field you are, that what we need the most now is collaboration. And that is why this is very important. So this is naturally what I would do, and a lot of coaches would do that. I have a lot of friends that are psychiatrists, that are psychologists. When I get a call, I know who to send them to. When they are done, they get back to an hour and say, or get back to a life coach and say, I need you to work with this person to move this person further. There is no need everybody trying to own your space and say, no, you are the life coach, you are the psychologist, you are the psychotherapist. No, we can't continue to do that. Every time we do that, we create that marginalization in this space. Someone is suffering, and it is the person with the mental health illness. What we need the most now is collaboration. I must also quickly say that the average life coach in Nigeria now know that they have to study one form of therapy or the other. So I see a lot of coaches beginning to study and get certified in cognitive behavioral therapy, even at the basis. And that is because we meet challenges every now and then that, let me put it this way. The average challenge a life coach would meet on the field today requires one little therapy or the other. So it is important to begin to relate with a life coach about your skill as a psychologist, about your skill as a psychotherapist, as a psychiatrist, and see how we can all work together to help that average human being. The post-COVID-19 lockdown world is a very challenging world. People are stressed like never before. People lack like never before. People are going through several types of challenges. Our most important goal will be to collaborate like we are doing right here in this program with the life of the average man out there who's got illness. So the role of the life coach is to work with all of you that are here, to work with you to refer people to you based on your profession and to work with them after they've left you so that we can create a whole human being. We believe that humans are whole and irrespective of the challenges that they are. And the solution to whatever challenge they have is within them. And we have been trained to find that strength, give it to them so that they can move ahead and achieve their goals in life. So I'd love to see where this discussion would end in terms of collaboration and moving forward to help people. Thank you so much. I'm so glad that we're doing this. Thank you very much, everybody.
Thank you very much, Mr. Enahoro, my honorable president. I'm glad to say that I'm also a member of ELCAN, and I do agree that there is a need for collaboration between life coaches and other mental health practitioners. Thank you very much, Mr. Enahoro. Good to have you here. I hope we're having a good time learning here, and I hope we are putting down notes and we are looking forward to implementation. All right, so without further ado, there is no way we'll talk about mental health and we'll not talk about counselors. They have a huge role to play. Mental health healing, or whatever name we want to give to it, is all-encompassing. It's multidisciplinary in nature. So, moving on, I will be introducing our next speaker, who happens to be the Vice Chairman of Lagos Chapter Counselors Association of Nigeria, Dr. Mustafa Toyin Sembe. Please forgive me if I did not pronounce that name correctly. Is a multidisciplinary professional. He trained as a teacher, agriculturist, counseling, and clinical psychologist. Dr. Mustafa holds full membership and is an active member of the Nigerian Association of Clinical Psychologists, Nigerian Psychological Association, and Counseling Association of Nigeria, CASAN. He is currently the vice chairman of CASAN. His research included perceived stress and hardiness as predictors of psychological well-being of civil servants in Lagos State, amongst others. He loves brainstorming exercises, lifetime and life-wide teaching and learning, adolescent and youth development issues, clinical practice, family dynamics, and psychological well-being, both objective and subjective. He loves reading, traveling, playing table tennis, and social interaction. Today, he will be speaking to us on the topic, driving stakeholder engagement from start to finish. Ladies and gentlemen, please make welcome Dr. Mustafa Toyi Sambe. You're welcome, sir. We can't hear you, doctor. The audio is not connected. Your video is connected, but your audio is not connected. Okay. So please unmute now, sir. You need to unmute. Doctor, please unmute. I've given you the permission to unmute. Just click on the microphone and you will be able to unmute. Okay, great. Can you hear me, sir?
Yes, I can hear you.
All right, sir. Over to you, sir. You're welcome.
Okay. Good morning, ladies and gentlemen. Afternoon, evening, or whatever time it's like. My name is Dr. Mustafa Toyin Sobe.
Can anyone else hear Doctor?
However, hello? However, for the purpose of today, I will be looking at driving stakeholders' engagement from start to finish. In my perspective, I have looked at stakeholders from numerous angles, including parents, siblings, neighbors, teachers, friends, well-wishers, faith-based relationship colleagues, which include Christian religion, Islamic faith, traditional faith, playmates, mosques as institutions, churches as institutions, and other faith institutions. We look at governmental organizations, non-governmental organizations, peers, friends, well-wishers, and so on, including former caregivers. Former caregivers are referred to professionals who give care, either in terms of prevention of mental illness, or in the treatment of mental illness, or in the rehabilitation and reintegration of individuals who have suffered from mental illness. And of course, this includes psychologists, psychiatric nurses, psychiatric social workers, occupational therapists, and a host of others. To my mind, start to finish will mean looking at this view from head to toe, or longitudinal view, as we call it, holistic perspectives, and what are or who are likely to contribute to mental health or mental illness, which is inclusive of nature and nurture dynamics. By nature-nurture dynamics, we mean what are the hereditary components, or what is commonly referred to as genetic components, that this individual has inherited from the parents that may predispose the individual to mental illness, or nurture the environment. For example, it is commonly said, show me your friend and I will tell you who you are. It is assumed, and more reliably so, that more often than not, somebody who is coming from Mushin, Oshodi, Ajegunle in Lagos, for example, will more likely be predisposed to the use of substances. Not necessarily that everybody that is raised in that environment would necessarily use psychoactive substances. In other words, when we look at start to finish, we are going to be considering issues of pre-marriage to marriage, pregnancy condition, during pregnancy activities. Some mothers may add or have falls. That means falling in an uncomfortable situation that may impinge on the well-being of the unborn child, which of course naturally may include the mental well-being of the child. The circumstance of birth, either prolonged labor, issues of delivery, safe delivery, unsafe delivery, where the child is delivered, who delivered the child, infection at birth, how treated, the diet and a host of other environmental issues that will coalesce to form what we look at as nurture, which we can't run away from the schooling type. The parenting, is the parenting the hazardous parenting type? Is it an absentee parent, or are we looking at motivating parenting or demotivating parenting? What are the predisposing factors, the precipitating factors, and likely perpetuating factors of mental illness? Or what, for me, try as much as possible to look at prevention of mental illness. And when we are looking at treatment modalities, we look at biopsychosocial spiritual modality. I should like to know quickly that in Nigeria, we are still essentially logged at the biological angle. And those who will not key into biological angle, key into the spiritual angle, forgetting that the individual did not come down with mental illness, either essentially, spiritually, or biologically, but more importantly, psychosocially, which is falling squarely within the purview of what the psychologists should have the capacity and training to handle. That is why you find out that in Nigerian books, you have good works written there. It is expected that community should have counseling units. Schools from primary or nursery and primary should have counseling units or psychological units or learning support or whatever nomenclature that will be applied. But as I speak with you, how many institutions in Nigeria do have this? Yet, all of these institutions get approval. In the concept of that work, it is expected that the child has some concerns. You marvel at what revelation will come out, where if you are able to sincerely motivate a child to talk about his or her parents, some will feel very strongly that their parents spend more for friends than for the home. Some will feel very strongly that their parents are careless, that they don't want to listen, that they don't have the capacity to solve them. Rather, they push them to other professionals. These are issues. So we look at rehab and reintervention. Let me wrap up this for the preparation of questions that by all means, treatment with education, which is falling squarely within the purview of the psychiatrist, a formal caregiver. Psychosocial falling squarely within the purview of the psychologist, and the spiritual falling squarely within the purview of the chaplain, either Muslim faith or Islamic faith chaplain, Christian faith chaplain, or traditional chaplain. The process of integration will look at stigma, which is a major issue. More important, self-stigma is of major and significant concern. And it is within the purview of the psychologist to prepare the individual, the family, and other stakeholders to recognize the fact that any
Seems like we have lost.
body can really break down. Yusuma? Hello? Hello?
Go on,
Hello?
sir. Go on, go on.
Am I still not within my time? I think I'm within my time.
Yes, you have 1 minute more, sir.
Okay. Thank you very much. The self-stigma is a major issue, and in society, everybody that I have highlighted earlier, which include the parent, the home environment, church, mosque, school, the peers, should have to look at how they resolve this issue and accept the individual as just like having a headache. And the individual having a headache can take whatever medication and natural support or natural and get over it. I want to thank you.
Okay,
questions. Thank you very much.
All right. Thank you very much, sir. That was Dr. M.T. Sambe. Thank you for that wonderful talk and explanation, and doing excellent justice to your topic. Moving on quickly without wasting our time, we have next someone, a doctor, a consultant psychiatrist, who will be speaking with us on the topic exploring solutions to the lack of mental health expertise in the nation and how we can strengthen the community sector and the peer workforce. Dr. Timothy Adibowale, an astute clinician and experienced mental health service administrator with full and specialist registration of the Medical and Dental Council of Nigeria and the General Medical Council, United Kingdom. Currently serves as a consultant psychiatrist, general adult community and rehabilitation psychiatry, and director of clinical services in Nigeria's foremost mental health care training and research institution, with formal training and ample experience in community mental health service planning, delivery, evaluation, and research. He also functions as program coordinator of the ARO Primary Care Mental Health Program for Ogun State. Ladies and gentlemen, please make welcome Dr. Timothy Adibowale, consultant psychiatrist and CEO, Hope Resource. You're welcome, sir. Over to you.
It's a good afternoon, still good morning. Okay, good morning. And I am Dr. Adibowale, as we've heard. I want to thank the organizers for inviting me to this symposium. And I have some slides, but to share it will be some problem. So let me go ahead first. Maybe eventually I may be able to share them. So I've been asked to speak on two things: exploring solutions to the lack of mental health expertise in the nation. Yes, let me acknowledge Professor Sheikh there. Are you still there? Thank you for that presentation, wonderful. So when we talk about lack of mental health expertise in the nation, my first take, and what I tell people anywhere, with all my experience over 3 decades in mental health service, is that regarding the problem that we have in the nation, mental health problem, the problem is not much of resource inadequacy, but more of mismanagement of resources. We have ample resources in this nation. And that's why in the diaspora, go to UK, go on the GMC register. If you see the number of psychiatrists, Nigerian psychiatrists there, you'll be amazed. Then go to the US, just talking about psychiatrists now, but now talking about other mental health professional, nurses, psychologists, occupational therapists. We are all over the world. So our problem, I tell us, is not really of inadequate resources, but just as we have not been able to manage most of our resources, including natural resources, we have poorly managed even manpower resources in this nation. So that's one of the things. So this is occurring in the context of what we've heard from Professor Sheikh about obsolete policies and legal framework driving mental health service in this nation. Apart from that, we also have deficiencies in our institutions and infrastructures. And sorry to say this, but without apology again, there is also poor professional commitment to service delivery. And so some of these are really what appears to be as if we have inadequate mental health expertise in this nation. Yes, the number 250 over 200 million, yes, it looks small. I've been to nations in this continent where there are fewer mental health professionals, and they are doing wonderful work, providing mental health service to their people. All we just need is to coordinate what we have, organize, do what some of the things we've mentioned about task shifting, task sharing, and the whole work will get done, using all the resources we have. Just as the last speaker also mentioned, mental health is not just a biological phenomenon, it's biopsychosocial, including community resources. I was talking to some of our trainees recently, talking about how to collaborate with, some other, even non-orthodox, cultural practitioners. And I do a lot of that over my 30 years practice, not sitting down with the Babalawo to divine anything, but no, I know when to ask a client to invite his pastor to me, to discuss some things, because I know he might be able to resolve some conflicts better than myself, because that is the area. The client will have confidence in what that person is able to do. For instance, I can't tell somebody who feels his problem is because he felt he has sinned and he's having all sort of psychosocial, psychosomatic disturbances. I can't tell him your sins are forgiven. Who am I? But his pastor may be able to tell you, don't worry, son, your sins are forgiven. I've had experience like that. Invite your pastor, let me see next, and then we discuss the problem. By the next time this person will come, all the symptoms are gone, because we were able. That's what we're talking about, collaboration. Understanding this person from cross-cultural point of view. So that's really, I'm talking about exploring solutions to lack of mental. Yes, I can say, let's go and train more manpower, let's open more school of nurses and this, yes. But the more we train, if we are not able to manage what we have, then we are not going anywhere. So that's my first point. And as I said earlier, this mismanagement of resources is not just limited to health or even mental health. It's in all sectors of our national life. It's a pity. So then, so we need a national value orientation away from the current pervasive, I don't know how we got there, indiscipline, self-centeredness, some form of narcissistic greed and all that, which are, and these are all expression of poor mental health as defined. We know what mental health is: a state of well-being of the mind, which has to do with, even knowing your potentials, coping with challenges of life, channeling, those strengths into survival means of productivity, and then contributing to the society. So these are these dimensions, and we know from what we have defined, there's nothing biological in it. It's really biopsychosocial, and so we need to rethink and really get these things, sort ourselves out. I think I'm just creating things for us to discuss during the discussion forum. So then the WHO mental MH gap program, which started since the early 2000, but by 2008, this big document on MH gap, that's mental health gap action program, that tells us about the gap between the resources and the need in every nation. Yes, we say it's more in developing countries, but more because of what I've said. Yet it exists everywhere, even the most developed nations of the world. There's that gap because there's a level of mismanagement everywhere. And the PHC, primary health care, it's been said to be a vehicle to meet, that mental health need of any entire population. I personally, between 2009 until I, disengaged from active civil service, that was last year, I coordinated the integration of a functional mental health program into primary care for the entire Ogun State population. That's over 6 million. And I can tell you up to now, the program is still on. In all the local government area of Ogun State, mental health services delivered at primary care level. Not all the primary health care centers, but in each local government, we have select mental health centers that, or primary care centers, both in the urban and rural areas, that provide mental health service. A well, solidly, planned and executed program, still functional. So we're talking about going to PHC. I mean, obviously, if somebody has any condition and he cannot go to the nearest health service to him to get, attention, that means the problem is not, if you need to travel, to the capital states, yes, we have the federal neuropsychiatric hospital. Those are not solutions to mental health, problem in the country until, the decentralization that we had, Dr. Sheikh said. And then really this integration we are talking about, which I can tell you is feasible, is possible, is doable. And when you do it right, it's functional and it's enduring. And it can really be sustained, it's sustainable also. So enough of that. Let me talk about strengthening the community sector and the peer workforce. Yes, in line with what I've said earlier, I'm only stimulating our thoughts about these things, not so deep. It will take a better professional commitment and informed, mobilized, and participating stakeholders and the community as a whole. Not necessarily the policy makers, the politicians. No, it takes the professionals. I mean, for instance, the program I say we ran at the Neuropsychiatric Hospital, which I coordinated, was because of professional commitment. We felt, no, we must take mental health service too. I mean, there's a big gap between tertiary service and primary care, but it took institutional commitment and professional commitment, doggedness to really do it, to break barriers. Is it barrier between the federal and the state, between the state and local government? It's as if, come and see where you are, don't come and see what we are doing here. But it takes, and then by the time you finish such program, you are able to lead across frontiers, and these are some of the things that it really, and it takes, a well-informed and mobilized community and stakeholders for them to say, wow, that's true. What you are saying is true. Let's try it. And so a lot of that is about strengthening the community sector and also mental health professionals being able to work intersectorially. Mental health is not, by the time you gotten this person treated in the hospital, and then you say, oh, it's well enough, let him go home. Even the family members are already protesting. Now, is it well enough? Please let him still stay in the hospital. I'm talking about severe mental health problems here. Let him still stay. And I tell you, close to 30% of patients we see in federal neuropsychiatric hospitals are either abandoned or neglected. That is, number one, they are either not visiting again and not paying any fee. I mean, most of the fees. And I will discuss with some of my colleagues from, then with the family members. And we say confidently, yes, they have the fund, they will get it.
Hello, doctor, are you still there?
Having said that, as I round up, so yes, you also asked me to speak on peer support. Yeah, that's an area I'm actually experimenting in my new project, experimenting with peer support in mental health. This is drawing lived experience of mental health challenges, to including drug abuse to support others with current problems. We're trying to see how this been done in most, been practiced in places outside here, this client, using people. Others. It became popular with drug abuse, with the Alcoholic Anonymous and other, but even in core functional mental disorders. So peer support work involves people with lived experience of mental illness, providing support or services to others with a diagnosis of mental illness. And this is an area we've not really looked at. Well, we had a long stay ward then, and we will use some of those who have been there for long. They had no place to go. They've been abandoned. Their homeless. They stay in the hospital. That's their home. But we use them to really offer support to the others. A bit. They're not abused, but that's some of the things we're talking about. But now I'm actually. Sorry, is my time up?
Yes, sir.
Okay, so let me just round up with this. So the peer support movement will be a good way also to augment. That's what I'm saying. We need to be able to exploit all the resources that we have, including that peer support to really get the work done if we really want to provide mental health service to the general population. Thank you very much for listening.
Thank you very much, Dr. Adebowale. I know that your topic is quite an enormous one. It's a three-part topic, and you're trying as much as possible to touch each part of the topic. We do appreciate your effort. All right. I hope we're all having interesting times. Please, you can drop your questions in the chat room. When it's time, they're going to be picked from there, and the facilitators or the speakers are going to address them. Moving on, as we need to make good use of our time, we're going to bring on another expert who is going to talk to us on trauma and the impact on the collective landscape in Nigeria. Dr. Folashade Olajubu has been a qualified medical doctor for over 30 years. She is a senior mental health professional who has worked in the arena of mental health in both Nigeria and the United Kingdom in a variety of capacities in both the public and the private sector. Dr. Olajubu currently works as a consultant forensic psychiatrist, working between interface of the criminal justice system and secure psychiatric services in Kent, the United Kingdom. She is a UK General Medical Council recognized trainer. She works in medical education and is the Forensic Training Program Director for Health Education, England, Kent, Surrey, and Sussex. Dr. Olajubu is an accredited therapist in cognitive analytic therapy. She is also an honorary senior lecturer with Christ Church University, Kent. Ladies and gentlemen, please make welcome as she speaks with us for the next 10 minutes on the topic trauma and the impact on the collective landscape in Nigeria, Dr. Folashade Olajubu. Over to you, Doctor.
Good afternoon, distinguished ladies and gentlemen. It is a privilege and an honor to be able to speak very briefly this afternoon at this first Nigerian Behavioral and Mental Health Symposium. I thank you for the kind introduction, and I want to start by saying a special thank you for the personal invitation from Professor Marino. I'm going to try now to share my screen. So if somebody could just indicate to me if they're able to see my screen, please.
Yes, we can. We can.
Thank you very much. So today I've been asked to just speak very briefly on trauma and the impact on the collective landscape in Nigeria. And I would like to start by just giving a set of definitions so that I can be sure, or we can all be sure collectively, that we are speaking about the same thing. I want to say that I'm quite excited to be at this symposium today, even though I'm here very briefly. And I remember that just about 15 months ago, I was at another first in terms of I was at the first National Suicide Prevention Symposium, which was held at the University of Lagos. And why am I excited? I'm excited because I believe at last we in the nation of Nigeria are beginning to have the conversations about mental health. It's fair to say that as a clinical practitioner, mental health is often viewed as the Cinderella of medical practice. And in reality, I would say that in Nigeria, we are just beginning to come to the table to talk about mental health and to recognize in terms with the WHO definition of health, that, you know, health is not just the absence of disease, but it is physical and it is mental and it's psychological and social well-being. So in many respects, if we are not considering mental health, if we're not considering mental well-being, then we are not really taking a holistic view of mental health. So in terms of talking about trauma, which I've been asked to, I want to start with some definitions, because again, trauma for many people is a really new concept. And yet in reality, as I break it down, we will all understand that psychological trauma is common to probably almost everybody in the Nigerian setting. So in terms of a generic definition of trauma, trauma is the response to a deeply distressing or disturbing event that overwhelms an individual's ability to cope. It causes feelings of helplessness, diminishes their sense of self, and their ability to feel the full range of emotions and experiences. So the key word there is deeply distressing, disturbing event, perceived by the individual as overwhelming, and it evokes in that individual a sense of helplessness and an inability to feel the full range of emotions and experiences. And when I think about mental health, I know that Dr. Adeboale provided us with the recognized and the standard definition of mental health, which I completely agree with. But when I'm talking to lay people, I say that mental health is that aspect of our health which involves our thinking and our emotions and our will, our cognition. So obviously, if somebody experiences trauma, those aspects of their health will be affected. Thinking a little bit deeper about and expanding trauma to psychological trauma, it's damage to the mind that occurs again as a result of a distressing event. And trauma is often the result of an overwhelming amount of stress that exceeds one's ability to cope or integrate the emotions involved with that experience. And I would like to suggest that living in Nigeria is a very stressful experience. I was in Nigeria for the whole of January. And I have to say that being privileged, or not so privileged, so to speak, to live in the United Kingdom, I'm always struck when I come home to Nigeria that things that realistically didn't ought to be or shouldn't ought to be stressful can be incredibly stressful. So for example, just going through immigration or sitting in hours and hours of traffic. So I would like to suggest that trauma is common to all of us. So now having given a generic definition of trauma, it's important to say that there are possibly three main types of trauma: acute, chronic, and complex. Acute trauma, it mainly results from a single distressing event, such as an accident, rape, assault, or a natural disaster. The event is extreme enough to threaten the person's emotional or physical security, and the event creates a lasting impression on the person's mind. And if it's not addressed through medical help, it can affect the way the person thinks and behaves. And I will possibly later on just go through some symptoms of acute trauma or other forms of trauma. Chronic trauma, on the other hand, happens when a person is exposed to multiple long-term or prolonged distressing traumatic events over an extended period. Chronic trauma may result from a long-term serious illness, may result from sexual abuse, may result from domestic violence and bullying, and exposure to extreme situations such as war. And several events of acute trauma, if they are not remain untreated, may progress to chronic trauma. And then we have complex trauma. So complex trauma describes both the exposure to multiple traumatic events, often of an invasive and interpersonal nature. And I emphasize on the interpersonal nature. A lot of times when we come across patients who have complex trauma, the traumas have been experienced within the context of their interpersonal relationships. And the challenge with complex trauma is there are wide-ranging long-term effects of this exposure. The events that the person has been exposed to are pervasive and severe, such as abuse or profound neglect. I think it would be amiss of me in talking about trauma if I don't think about the concept of adverse childhood experiences. Now, all of us, or all of you who work in the domain of mental health or in clinical practice will know that an individual's experiences in childhood and adolescence will have an impact on their health in adulthood. That is true in terms of physical health, and it is especially true in respect of mental health. And so there is a concept known as adverse childhood experiences, which essentially basically states that if a child is exposed to some of these adverse experiences, which I'm going to list, then it is likely to have a deleterious impact on their mental health in adulthood. And some of these adverse childhood experiences are emotional abuse, physical abuse, sexual abuse, children who have witnessed domestic abuse in the home and they witness their mother being treated violently, substance abuse in the household. So that is in the Nigerian context, it would probably more likely to be within the home, alcohol abuse. But of course, we're quite cognizant now that, the forms of other illicit substances such as cannabis are becoming more rampant in our environment. Mental illness in the households. For the clinicians amongst us, we understand that if one individual in the family has a mental illness, it is not just that person who goes through that process. Every member of the family household is involved. And if it happens to be a parent who has a mental illness, then other things are likely to evolve, such as child neglect or sometimes abuse. Of course, going on to parental separation or divorce. I once heard somebody say that when individuals divorce, there are no winners. And definitely in terms of parental separation or divorce, it has a negative impact on the children in terms of their sense of security and attachments. Incarcerated household member. So we think about in the Nigerian context, there are sadly still a lot of women who are classed as second-class citizens in our culture. And I am in no way subverting our culture. There are many very positive aspects about our culture. But sometimes within the context of marital relationships, the woman is subjected to abuse and a lack of appropriate freedoms, I would say human rights. And when an individual or a child experiences those things, it has an adverse effect on their mental health in adulthood. And as I've alluded to, emotional neglect and physical neglect, forms of abuse as well. So what do these do? I then had a little bit of a think about just living in Nigeria and some of the traumas that I think are specific to, our home environment. This is not an inexhaustible list, but some of the things that I think are worth highlighting. So intimate partner violence, I don't have the statistics here, but I remember speaking at a symposium a little while ago about intimate partner violence in the Nigerian context. And it was quite worrying that over 60% of educated women and close to 60% of uneducated women had experienced intimate partner violence in their relationships. In fact, I understand from the WHO that we were deemed as a nation that had one of the highest incidents of intimate partner violence in the world, which is shocking. But you can also imagine then the traumatic impact on children and adults who are either witnessing or the victims of partner violence. Of course, bereavement is universal to all of us, but the loss of an individual, especially in traumatic circumstances or suddenly, or where there have been difficulties in the relationship with the deceased, can become a traumatic experience and lead to psychological trauma. It goes without saying that in the Nigerian context, sexual assault is a traumatic experience. And unfortunately, incest is the elephant in the room. We just really don't talk much about incest or abuse. Of course, common to our some of the cultures in Nigeria is female genital mutilation. Polygamy. Well, some people may say, goodness, Folashade, what are you saying? Of course, sometimes polygamy is very healthy and does not impose any kind of trauma at all. But it really does depend on the setup. For many women living in a polygamous environment and the children, it can be quite traumatic. And in the Nigerian scenario, infertility. So unfortunately, a lot of times when a couple is infertile, it is the women who bear the brunt. And I've highlighted this actually because next week, the 8th of March, is the World Day for Women. And in the Nigerian context, I mean, I practiced in Nigeria when I first qualified. And it was quite common to see couples come in and the woman is being blamed for infertility, when in fact it is actually the gentleman who has the clinical issues. But the way in which we respond to infertility in our culture can be very traumatic for women. And then I thought about some more general, can I say, environmental collective areas that cause trauma in our environment. So road traffic accidents, which unfortunately are quite rife in our community. More recently, and sadly, terrorist acts. I put my disclaimer out there. I'm not a politician, but I think we're all aware of Boko Haram, etc., etc. Of course, recently we had the protests in Lagos, and that related to enforcement agency brutality. And I would say that that has not been resolved. I would say that it is something that we constantly experience within the Nigerian context. Then we think about security, so kidnappings, ritual killings, and robberies. And of course, poverty. Poverty is rife in our nation, sadly. The very big disparity between those who have and those who don't have. And all these things are causes of trauma. And then, as I said, my disclaimer, I'm not a politician, but I think that intertribal conflict also leads to trauma and the very workings of our system, which is often very corrupt. So I'm just reminded of recently being in Nigeria and facing corruption right as I go through immigration, where I have done nothing wrong, I'm not concealing anybody, and immigration officers are openly asking me for money, you know, and what do you have, madam, kind of thing. And unfortunately, corruption, dishonest and fraudulent conduct has become embedded in our society. And these all, believe it or not, are forms of chronic, I would say chronic trauma. And then again, I think we need to think about COVID. So I know that I believe at the moment that COVID is really impacting on what I would define as the middle class in Nigeria, where most of us from our particular background will know of people who sadly have passed away from COVID. And of course, all the socioeconomic impacts of COVID in the last year. So what are the trauma responses when an individual is exposed to trauma, whether it's acute or chronic or complex? The impact of the trauma will be very much dependent on a number of domains. So first and foremost, the nature of the traumatic event, but then other things come into play as to whether that person goes on to experience complex trauma or chronic trauma to manifest the symptoms. And that includes genetics. And I quickly always put out there that we can't change our genes, but there are other things that we can. So if an individual has ongoing life stresses or has a lack of support, or is dealing with multiple stresses and traumas, the individual who then goes on to experience another traumatic event is likely to have a more adverse psychological traumatic response. So the effects of trauma, early adversity that we talked about, and traumatic events have an impact on so many areas. So first and foremost, it can lead to traumatic brain injuries, but it can also lead to mental health illness such as depression, anxiety, post-traumatic stress disorder, and sadly suicide. One of the knock-on effects of trauma in childhood for women in particular is unintended pregnancies, fetal death, pregnancy complications. Of course, sadly, when people have been exposed to trauma in childhood and adolescence, it sometimes leads to what people might view as promiscuous behavior, sexual behavior, but is actually a response to the trauma. And of course, when you're exposed to trauma, it can also have an impact on your physical health. So for example, within our population, hypertension and diabetes arise. And of course, in line with mental health difficulties in terms of mental illness, it can also lead to difficulties with drug and alcohol abuse. So for the sake of time, this is a PowerPoint that just talks about many of the symptoms of trauma, which for we clinicians, when we come into contact with patients, whether they're presenting to us with a physical health issue or whether they are actually being bold enough to say they have mental health difficulties, we need to look out for. And some of them, I've noted them: depression, irritability, a loss of interest in life, numbing of emotions, decreased concentration, difficulties with sleep, feeling overwhelmed, a subjective sense of helplessness and hopelessness, a sense of shame and worthlessness, little or no memories. So people with trauma often talk about gaps in their memory, nightmares and flashbacks, hypervigilance and mistrust, anxiety symptoms, panic attacks, And then sometimes you have psychosomatic symptoms such as chronic pain, headaches, substance abuse, eating disorders, self-destructive behavior, and a lack of self-esteem.
Dr. Lajubu?
Yes, ma'am. I've almost finished. I've almost finished, ma'am. So I'm not going to go into the symptoms of trauma. These slides can be shared, but I just want to bring up as I come to an end, this tree is called the trauma tree. And it's really a pictorial depiction of trauma. So at the bottom, you have the roots, and these are the various traumas that people have experienced and may not be known to other people, may not even be known to the clinicians who see them. And at the top, you have the tree and it's all the symptoms. So what tends to happen is when you come into contact with an individual, whether in a clinical setting or any other setting, you are aware of these particular behaviors, but what may not be immediately apparent is that this person is exhibiting symptoms of trauma. So I just want to round up. I've got 2 more slides, and I want to put out the concept that I think people should think about today and for further consideration, a trauma-informed approach. So a trauma-informed approach seeks an awareness of the widespread impact of trauma on life experience and relationships, and it recognizes trauma's role in the outlooks and emotions and behavior of a person with a trauma history. And I would like to say that whether in clinical practice or in church or whatever domain that you come into contact people, we need to have a trauma-informed approach to realize that many people that we're coming into contact with professionally and personally have suffered from trauma. And I just want to end by saying we need to recognize that individually and collectively, we have all been traumatized. And our service provision, forgive me for the typo, must recognize that most, if not all of us, suffer or have suffered from trauma symptoms. Thank you very much for listening.
Thank you, Dr.
Thank you.
Olaju. All right, so we are pressed for time. So just to inform us that all our other speakers, please, you have 10 minutes. You're going to hear the first, my clap when it's 5 minutes. And then when you hear another sound, it's a sign that you need to wrap up. We don't want to keep people waiting for long. Thank you very much for that presentation once again. Moving on, we have an educator and the CEO of 3 Dimension EDBs and Associates, who is going to be sharing with us the topic undue stress and stressors in the education sector in Nigeria and as it impacts the mental health of teachers, learners, and all stakeholders. Mr. Akin Benjamin is a passionate teacher, inspirational speaker, youth mentor, and a social sector manager. He holds a bachelor's degree of the University of Ibadan in Education and Political Science and has taught in various international schools of repute in Nigeria. Akin Benjamin was programs manager and later acting executive director of the International Youth Enterprise Organization, Junior Achievements Nigeria, where he trained many youths in and out of secondary schools in Nigeria and Kenya. He is a Coca-Cola African Scholar and an alumnus of the Africa America Institute, New York, and the Enterprise Development Center of the Pan-Atlantic University, Lagos, Nigeria, where he was in the first set of the social sector management program, jointly organized by the 2 institutions earlier mentioned. He prepared the Black Diamond Students Company of Dowen College, Lagos, Nigeria, to win the first ever HP Responsible Business Ideas Contest in Africa in 2009. He's fully involved in raising responsible young adults who are fully equipped to function profitably as global citizens wherever they find themselves. Finally, he is the convener and executive director of the advocacy group, the Supportive Discipline for Dignity Initiative. Ladies and gentlemen, please welcome Mr. Akin Benjamin, who in 10 minutes will share with us on the issue of undue stress and stressors. Over to you, Mr. Benjamin. Your time starts now, sir. Thank you. can't hear you. Yeah, your network is not helping us.
Hello, am I audible now? Hello? Hello?
Yes, we can hear you.
Hello? Great. So I guess it's a video that. So I was saying that I intend to give a feedback from the field, at the education field and sector. Stress, the kind of stress we face as stakeholders in that sector in Nigeria. And I'm hoping that I'll be as audible as possible. Now, I want to start from the school owners. I may not touch more on government. I just want to talk about those who are stakeholders in the sector. From school owners, people who choose to establish schools in Nigeria. In the first place, a lot of very few education professionals are into the establishment of schools. And so, from the word go, a lot of people who may not even know what it entails are the ones who have got the money to establish. Sometimes expectations are not real. You know, maybe a politician that has got some good money wants to do business that he or she thinks will bring him money so quickly, and then comes into education. We've seen that several in places like Abuja, Lagos, and others. And then, because the returns in education and education investment is not like in other strictly profit-making businesses. Education business is a social enterprise, and it takes time. But because a lot of students come in with the wrong expectation, they immediately get into trouble. A lot of people have gone into heavy indebtedness to put the schools together. We have cases where, because of the pressure of returning, payment of loans and all that, some people have actually developed hypertension and all of that kind of died. We have instances. And so that is where I must begin to look at this. Who are the people who set up schools? What drives them to set up schools? And how do they come under serious stress by some of the ways they come in? Now, apart from that, they operate within a very harsh environment. I mean, to even establish a school, you may have to pay your way through on every table where people are involved in giving you permissions and all that. And then when you have established your school, you may have to pay through every time that you hear that inspectors will show up or something like that. So there is and not only that, multiple taxations for school owners. The other day, it was, a bus went out. Yeah, they arrested the driver, and then they said because he does not have a basket, a local government given basket in the bus, and he has to pay. I said, well, we can buy a basket and keep. No, they said we must get from us. And that they now issued is a receipt, I think about 20,000 or so for a basket. And they gave all manners of things in that, justify this. There's a harsh environment that is not conducive, puts pressure on those who run schools. Not only that, the challenge of getting skilled, well-trained hands. The teachers that we have today, a lot came to the profession because it became a dumping ground. So many people are not passionate about it, so many are not skilled, and there is a dire need for teachers. So sometimes schools recruit, and then in the process of their delivery, there is serious pressure because job is not done well, and these are people having an entitlement mentality who wants more than what they are putting in. So there's so much that I would say that for that as for owners of school. Coming to the teachers who teach. When it comes to teachers, and I hope I'm audible, please, because I hope I'm audible. I hope people are hearing me still. Now, all of those who teach in our schools, the stressors are just too many. Nigeria itself is a stress factor. You realize that the level of dignity, the way teachers see themselves, apart from self-inflicted low self-esteem, society has also done a lot to bash the teacher. The teacher back in the day was the respected headmaster, was the respected custodian of knowledge and all that. That has changed. Of course, knowledge is democratized, but then the economic status of teachers. I started teaching, for example, in Nigeria, when landlords would put on their houses rooms to let teachers not wanted. Rooms to let teachers not wanted. Teachers could not afford to pay rent. That alone, the economic returns of the job, which is so demanding, the economic return is so little. And I'm not talking about those who have entitlement. I'm saying the economic returns, if you hear the kind of remuneration that teachers get in this country, you will be amazed. You will be amazed. And so we have a largely unmotivated teachers in the classroom, coupled with the fact that they themselves largely are not skilled. And so we have troubles on our hands. Apart from that, the fact that, yes, even commuting, I remember that I was living in Ikorodu. I was teaching on the island at Lekki. I needed to get to my bus station 5 a.m. That is in Lagos anyway. It will be different in other parts of the country. But you have to be there. That means you've woken up around 4 or 3:30. It means that, and you are going to get back home around, say, 12, 10 p.m., 11 to wake up. So there is a build-up of tension and stress on the teacher, leading to burnout and sometimes transferred aggression. All of these things bring about attrition in the teaching and learning. You see, there's no way to not impact on what is going on in the school system. We're looking at the class number, the number of pupils per teacher in this country is something else. I am involved in training teachers on supportive discipline approaches. Teachers tell you how to do this with 80 class, especially public schools. Some private schools have as much as 40 in their classrooms. So we have a real problem facing teachers in the classroom, starting from the fact that they are not properly skilled. A lot of them are not being trained. Some schools don't train their teachers. Both owners of schools and teachers need to develop emotional intelligence. One, on the part of the students to manage the staff, on the part of teachers to manage themselves and manage the children that they teach. A lot of people unleash anger on these children. Harsh and violent punitive measures. Nigerian teachers are still arguing. They are debating whether they should drop corporal punishment and harsh discipline. Some of us are all over, we are on the field training. So I'm talking to you now. In the next 1 hour, I'm training some teachers in a particular school on positive discipline strategies. Our teachers want to continue to do it the way of the old, which is wrong. And so now that is just one. Two is in the terms of the kind of contracts that teachers sign when they want to take up job. Some contracts that they sign with school owners are slavish contracts. That puts them in real slavery, almost near condition. And I don't want to emphasize on that, but that is the reality. Okay. Moving on from there, I will talk about the children themselves. Children are going through a lot, and the stress that they bring from home, homes that are already challenged, homes that the parents are coping with harsh economic conditions. Some have taught a child who would witness so you almost want to kill. We have to set up anger management therapy for this child. A lot of things. From home, stress themselves, economic activities of the home, who are bringing in income at very tender ages. Street trading for children, because children must bring in income and all of that. Some children have gone to school, quickly settling before they come to school in the morning. These are issues. And then, of course, the idea that they come to school, the teacher is not even asking why they are late. The teacher is not asking, the teacher is not bothering whether they are stressed already. The teacher wants to push anger and do harsh punitive measures. These are things that goes on in our schools. And when we talk about intervention along these lines, I am expecting that, when we talk some schools, some highbrow schools, so even set up a learning support center, just even for those special needs, those for mental health needs. They begin to look like, they will label our school as a school for people who are for mentally ill. We have a long way to go. Some schools don't want to be labeled. They say parents will run away. They will take their children. The moment you have a center where you are attending to mental health, where you are attending to special needs, and I've thought that strong, So we need to begin to set up, be deliberate about interventions in these areas. How do we increase the capacity of our schools, teachers? How do we? I'm looking forward to the day when the school counselor will be a very, very trained professional that is not just there as a figurehead, but is providing mental health counseling and interventions and therapy for both children, teachers, and learners. So that in schools, the counseling department becomes more functional than what we have now. Because what we have now is that some people just take up the job, they may not know anything, they may not be able to do anything. So that's a place where we can start from. That whichever counseling department in the school should be field skilled professionals, mental health professionals that can help special needs counseling, well-trained counselors that can help, so that we don't have burnout. So that we manage the school owner-teacher relationship, where you need to see the interaction, the kind of pent-up anger inside of teachers towards employees, and that affects their work. So I'm talking from somebody who is on the field, who sees, who has experienced this, and I've experienced some of these things myself, and I'm saying that we really need intervention from professionals. So please, I hope that this conference will be one that will throw up relevant interventions for my sector, the education sector in Nigeria, so that we can have a better environment, a social and emotional environment to work in, and we can be more productive, so that the teaching and learning can be what we should be. Thank you very much.
Thank you very much, Mr. Benjamin.
Thank you very much.
Thank you for that insights into how mental health runs in schools. All right, so we're moving on to the last name on my list here. After now, we'll go on a very short break. Our next speaker is Professor Olatunji Aina, who is a psychiatrist at Luth. I'll read his profile briefly. Professor O.F. Aina qualified as a medical doctor with MBBS degree from the University of Ilorin. He went further to specialize in psychiatry and was awarded Fellow West African College of Physicians. He is the immediate past head, Department of Psychiatry, College of Medicine, University of Lagos. Professor Aina is an external examiner in various Nigerian universities. He's also an external examiner in both MBBS final and master's degree programs at the University of Ibadan. Professor Aina is editor-in-chief of the Nigerian Journal of Psychiatry, the official journal of the Association of Psychiatrists in Nigeria. His areas of research interest are transcultural psychiatry, consultation, liaison psychiatry, and child and adolescent mental health. Professor Aina has over 70 publications in both national and international journals, as well as co-editor of 3 textbooks of psychiatry, 2 of which were published in the United Kingdom. He will be speaking with us briefly today on models of care and best practice for early intervention and prevention. Please join me as we make welcome Professor Olatunji Aina.
Toluche, can you hear me? Toluche?
I can hear you.
Yeah, Professor Aina got network issues, so we have to come back to him at some point.
Oh, okay.
Yeah, so this is a good segue for us to break. Let me just say a few words before we do. Spotlight me, please. Let me just say a few words before we do. Thank you so much for everyone that have spoken, all the professors and the doctors and the president of coaches of Nahoro. Thank you so much. This has been very powerful. I appreciate your time. You know it's not over. We have a question and answer time at the end. And so please make sure you wait till, because there's a lot of questions. We have, even before the presentation, we've had about 300 questions that were sent. We're not going to get to all of them today, obviously. People have questions, and I'm sure we all have the answers. Mental health is about wellness. So I wish you all well. This moment, we're going to take a 5-minute break. We're going to take a 5-minute break and then come back. But I want you to actually take a break. So that means don't go back to work, don't like, answer emails. Just kind of relax, breathe in and out. Make sure you take 5 minutes of your time, me time, and we'll come back at 1:05. We should be back and we will start with the next speaker. Thank you so much. we have about a minute and we're expecting everyone to come back. At this part, we're going to have Mrs. Grace Alexander, who represents the disabled community. We're going to have Reverend Austin, who is going to talk to us about religion, Christianity. Dr. Amina Mohammed Baloni is the Honorable Commissioner of Health for Kaduna State. She'll be with us. Dr. Olubemi Olukolade will be with us. Coach K, a fantastic coach, is going to talk to us about the mind. Toluche, who has been a moderator, the mentalist, this guy's an influencer, is going to be with us, at this segment. Eyitayo is from the Life Coaches Association. She's going to be with us. Dr. Oyebanji, Honorable Commissioner Dr. Oyebanji Filani is from the Ekiti State Commission, will be with us. And hopefully we also hope that our Commissioner for Health, Lagos State, will also be with us. So this is going to be a packed hour. At the end of this, I think at 8 or so presentations, we will then I'm going to be talking about innovations. I'm going to talk about innovation. I'm going to be talking about grants. I'm going to be talking about the way forward. What do we do from here? Where do we go from here? And so what then we need to do is, I think it's 1:06 right now. And then we will start with the first presenter. I want to present our moderator, Mrs. Binke. Where are you? I wish I had your bio so I can introduce you. But okay, Mrs. Binke, take it over. Thank you very much.
Hello, everyone. Welcome back. So welcome back. We would like to right now introduce Mrs. Grace Alexander. She is our next speaker, doing great work in the disability community. Mrs. Grace Alexander is the founder and CEO, Star Children Development Initiative and Star Children Initiative UK. Both organizations are non-profit companies that provide practical, sustainable solutions to the challenges faced by children and youth and women with disabilities and their primary caregivers in Nigeria and the United Kingdom. Star Children Initiative is also an international network organization founded on the principle of equality and justice for all that promotes equality. Oh, please, let me take that again. Star Children Initiative is also an international network organization founded on the principles of equality and justice for all, and promotes equal opportunity and inclusion for disabled children, youths, and women in our society. Mrs. Alexander also champions the rights of children with disabilities and educates parents and caregivers on how to support them, and also engages with the relevant private and public organizations, all with the aim of removing barriers such as stigma, cultural bias, prejudices that are associated with disabilities. Please, everyone, do welcome with me Madam Grace Alexander. Yeah, I'm looking for. Okay. She hasn't switched on her video. Please unmute yourself, ma'am. You've been asked to unmute. Ma'am, please unmute. You can unmute now, ma'am. Still not going.
Okay, hello everyone.
Okay,
Thank
we
you,
got you.
Professor Mario, for putting this together. I'm speaking from London. Thank you so much for putting this. This is actually overdue in Nigeria. And
Emma, we still can't hear you.
oh, you still can't hear me?
Yeah, we still can't hear you, even though we still can't
Oh, we
hear
can
you.
hear.
Yes, we can. We can hear.
Now you're muted.
She's muted.
You're muted.
Okay, hello.
Yeah, we can hear you
Okay,
now.
you can hear me now. Okay. Hello, everyone. I'm speaking from London, and hello, everyone. And thank you, Professor Marino, for inviting me to this gathering of giants of minds. And I'm standing on the existing protocol. And please, can you share my screen, please? And I want to actually applaud this event, and I want to applaud all the members that have spoken before me. I'm speaking from the perspective of being an advocate for persons living with disability. And I like to say that I'm a proud mother of a young man. My last son is 26, who actually lives with disability. That's the inspiration behind my organization. So can you help me to share my screen, please? Thank you, Bingwe. Thank you so much. And I'm going to say the connection, I want to say the connection between disability, mental health, and behavioral health. So next slide, please. Oh, sugar. Okay, next slide, please. Yes. So I will first of all define what disability is. According to WHO, disability is a difficulty in daily functioning as experienced by an individual with a health condition as actually in interaction with other environmental contextual factors. What I mean is that it's a lack of interaction between the impairment and other contextual factors. That means daily functioning and limitations, participation, and your health. It could be a health condition which can actually affect the way people respond to a lot of issues within their environment. But what concerns me there is that the lack of interaction. Then people forget that environmental factors can also cause a form of disability. And that environmental factors are the stigma, the myths, the taboo, culturally, your environment, how people perceive it can actually affect the way you react to whether you're a person that is disabled, or whether you have a child with disability, or whether you acquire disability, because disability is an evolving concept. So I want to actually, can you just reduce, because I can't see what is written towards the end of the screen. Pimpe, can you just so what is no Pimpe, the next one, no, not this one. Oh, sugar. Next, no, not next one. The one, what is mental health? So mental health has been defined by other people, but I would just say is, according to WHO, is a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, and can work productively and fruitfully, and is able to make a contribution to his or her community. So that is mental health. The next slide. What is behavioral health? WHO describe it as a connection between behaviors, the health, and the well-being of body, mind, and spirit. In other words, it means how behavior impacts on someone's physical health and mental health. So, or the action people take, or how you react to any form of like trauma, any form of unexpected incident, like if you are having a child with disability, or if you acquire disability, or anything that happens to you. Next slide, please. So how does mental health affect persons with disability? Having disability can increase the risk of mental health problems, according to Bond et al. 2009. Research suggests that adults with disability encounter frequent mental health, almost 5 times as often as adults without disability. And youth with disability can also can also experience lack of concentration due to peer pressure, due to environmental factors, poor relationship, aggressive behavior, irritability, and parents of persons with disability can experience change in family dynamics. I will use myself as a case case study. You are tired, the lack of unknown, the lack of sleep, that can affect a lot of things when you can be, and most of the behavioral changes include stress, irritability, that's the behavior. Then you can start taking drug or have alcohol misuse, mood swing, binging on food, bulimia, nervosa, anorexia, nervosa, etc., etc.
Hello, ma'am. Madam Grace? Okay, I think we lost her to the network.
Can you hear me? Doctor, can anybody hear us? I think it's us.
Yeah, I can hear you.
Oh, okay. So so it means that Mrs. Grace's network kicked her out. Hopefully she will come back. Please, I want to know if Dr. Aino is here. Is Professor Aino is here? Please initiate that you're here, because I can't seem to find you. Oh, I see Dr. Aino. Professor Aino, I see you. We're bringing Professor Aino back. So let's read his introduction and tell Auntie Grace will come later. Professor Aino, can you unmute yourself, please?
Hello, good afternoon. Hello.
Good afternoon. Let's reintroduce you briefly.
Professor O.F. Aino qualified as a medical doctor with an MBBS degree from the University of Illinois. He went further to specialize in psychiatry and was awarded Fellow of the College of Physicians. He is the immediate past head, Department of Psychiatry, College of Medicine, University of Lagos. Professor Aino is an external examiner in various Nigerian universities. He is also an external examiner in both MBBS final and master degree programs in the University of Ibadan. Professor Aino is the editor-in-chief of the Nigerian Journal of Psychiatry, the official journal of the Association of Psychiatrists in Nigeria. His areas of research interest are transcultural psychiatry, consultation liaison psychiatry, and child and adolescent mental health. He has over 70 publications in both national and international journals, as well as co-editor of 3 textbooks of psychiatry, 2 of which were published in UK. Please welcome with me Professor O.F. Aino.
Good
Sir, you
afternoon,
have
distinguished
10
members
minutes
of
for
the
your
panel.
presentation. Thank you.
Okay, thank you. Good afternoon, members of the panel, distinguished participants. I'll be talking
Looks like a network issue, Professor. I know we can't hear you. Can you all hear him? Solusha, can you hear him?
I can't hear you.
Solusha, can you hear him?
Not at all. I can't. I can hear you, but I cannot hear Prof.
Okay. So, Professor, I know we cannot hear you. I don't know what happened. I think it got kicked off again. Well, welcome to Network in Nigeria. What can I tell you? This is what it looks like, guys. We just have to roll with it. We'll give it 1 minute and then move on to the next speaker. Move on to the next speaker, which will be Reverend Austin. But let's make it just wait. Let's just wait a few minutes. I mean, 1 minute to see if we can get Professor Aino back. Thank you for your patience. So since we're talking about trauma, try not to get traumatized by any one of this network breaks and abnormalities here. So we are just gonna take a deep breath and move on. So everyone with me, we're gonna take a deep breath since we're talking about wellness and mental health conference. So what I want you to do is you're going to inhale through your nose and you're gonna hold it and then blow out through your mouth as if you were blowing through into a balloon. You are blowing into a balloon. So it looks like this. Inhale, hold, and then exhale. So let's all practice that. So let's inhale, everyone. Inhale. Exhale. All right, you should feel better. So all the network going in and out, that is what people here in this country have to deal and contend with every day. So I think Professor Aino is back. Professor Aino, are you there? So we can get on with your presentation. Can you hear us? I can see his name, but I don't know if he can hear us. All right. Okay then. Reverend Austin, are you there? And are you ready? Okay, Reverend Austin is here and is ready, so let's introduce him, please.
Well, network in Nigeria, we pray it gets better. Okay, Professor, I know I can see you trying to connect. Are you back? Are you back with us? Okay. All right. So, Reverend Austin, you are on. Reverend Austin, a Campus Crusade for Christ staff member since 1990, began his service with the campus ministry right here in Nigeria. He has served as a local campus director, the campus director for the Western Africa area of affairs, and field director of campus ministries for all of Africa, Central Asia, and the Middle East. Austin provided leadership for Pamoja Africa, a historical initiative to network and mobilize college students and young professionals in order to help fulfill the Great Commission. Reverend Austin was appointed Director of Affairs for West Africa, which includes 10 countries and nearly 400 missionary and salaried staff members. I am most excited about two things, Reverend says. One is that the body of Christ would be empowered to reach all of the rest of Africa with the gospel message. The second is that God will raise a significant number of laborers for Africa and the rest of the world. I believe strongly we need to have a greater understanding of Africa's place in God's plan for this generation. All that from Reverend Austin. Please welcome with me this great afternoon, Reverend Austin Okomowo.
Unmute yourself, please.
There you go. Well, good afternoon, everybody. I live in Accra, but I do happen to be in Lagos today. Let me leverage on all of the protocol formalities that have been done prior, and to leverage on that and just be able to speak with us. I want to say that I appreciate very significantly, and this time we're having together, it has been educative for me and very helpful for me as well. I look forward to being able to look further at the PowerPoints that have been presented and to collaborate with different ones of you going forward on the question of mental health in our beloved country of Nigeria. I currently reside in Ghana because of the work I do, but this morning I happen to be in Lagos. I'm going to be sharing with us on how to improve the integration of mental health services in faith-based communities, focusing on some core problems and some core outcomes that we need to be looking at. Professor Sheikh and other presenters have referred to the faith community in their presentations already. I'm just going to focus a little bit more on that this afternoon. Well, Nigeria is nothing as a country if it's not religious. Every part of our life, we're deep religious people. You could hardly meet a Nigerian who does not believe in God or in the spiritual aspect of life. In my a little more than 50 years of life, I have not met one yet, whether home or abroad. And this is regardless of economic positions, particular locations, unique ethnicity, education, or economic status. So we are a people that consider the spiritual not only an important part of life, but an integral part of our lives as well, whether we be Christians, Muslims, or people who practice our traditional African religions. And if one looks at the mental health situation of our country, I believe that virtually every Nigerian is engaged with some form of religion or the other. I would also almost say between education and religion, our religious institutions, those two are the aspects of our lives that virtually every Nigerian on a weekly, if not a daily basis, has an engagement with these institutions. And those two institutions also are very significant from very early in life in how they impact our experience in mental health, whether it be positive or negative, whether that is developing or regressing. So religion then is a major part of our lives and must be looked at as a major part of the mental health well-being of the whole country. Most of our people, when they think about their mental health, or when they begin to observe that they have challenges with regards to mental health, in most instances, would first actually approach a religious leader, be that a reverend, a pastor, or an imam, for many different reasons. Those are the institutions that they know that will deal with their the things they cannot explain in terms of body. There are a couple of significant problems with regards to religious institutions' involvement in and integrating a mental health awareness into our programs. One of the challenges to begin with, understand me, I think that the religious institutions serve our people well, to the best of their ability, serve our people all over this country well. They are involved in people's lives everywhere. They are changing people's lives for the better. As a matter of fact, one would say that with the challenges of our federation and our country, the religious institutions being present have been a very significant factor in the whole community not fragmentizing. But that being said, there are also challenges that are there. Because the religious institutions have a paradigm that focuses on the spiritual, the way mental health difficulties or trauma is interpreted in the religious context can be challenging. Can I get a feedback in case I am not being heard? Dr. Marino, can you hear me? Can anybody hear me?
You're loud and clear, sir.
I can hear you.
Thank you very much for the feedback. A couple of core problems with mental health and the religious community and institutions. First of all is that because of the nature of the institutions of religions, things are looked at from a spiritual perspective that may interpret mental situations in spiritual ways that may go beyond what is mental. We understand when we have a headache, but when a person presents particular behaviors, it may be given not so much a psychological or psychiatric interpretation, it may be given a spiritual interpretation. And once you have given it that interpretation, your primary solution is a spiritual one, which might be way beyond what is required in this situation. This is true for the Christian community, it is true for the Muslim community, it is true for the African traditional practitioners. In the Christian community, if a person behaves in particular ways, instead of asking the question that will help us understand their mental state and well-being, we may want to give them deliverance. The same thing is actually true in the Muslim situation. If you've been reading the news recently, in different parts of the country, particularly northern Nigeria, they found these homes where people that have mental challenges have been shackled and chained, and all kinds of things are happening with them. And it's assumed that they may have spiritual issues. The same is true of our traditional practitioners of religion and the way they understand it, because the paradigm is one of either somatic or pneumatic, and the psychological in the middle is missing. It's either interpreted as the person is sick in body, give him agbo or some concoction, or the person is sick with the spirit, so we need to exercise, we need to consult that. So this spiritual dimension, which is a necessary part of life for all of us, can become a core problem with in the religious institution and mental health. A second problem is that the processes that mental institutions use to, the processes that religious institutions use to try to address these problems when they perceive them, those processes themselves can be traumatizing or even make people with mental health situation worse because you don't understand it. So that's one problem. One problem is, the first problem is the problem of a worldview. The second problem is the problem of processes to deal with non-physical challenges that people face. The third core problem that I would say is there is that for people that are in the religious institutions, pastors, imams, I don't know too much about the African traditional religious people and how they get their training. The question of the mental well-being of human beings and the science of it that we have developed, over time, that some of our academics here have so eloquently shared with us, is not part of the content of their training in Bible schools or Islamia schools or in the traditional process. So the understanding may not always be there, except for those who have taken the additional burden upon themselves to learn, to go and learn in these areas. So because that is we talk about spiritual health, we talk about physical health, but the mental health situation is not addressed at the training of leaders of those institutions. It becomes a missing component in the practice of religion. Additionally, the many congregations where people come together actually to express and experience their religion, in those contexts, the question of mental health is not addressed as often and as intently. And which has been mentioned here also, a fifth problem is that access to mental health professionals, the understanding to be able to refer people to mental health professionals is very limited in the Nigerian context. So what we have then is that we have religious leaders who are doing the best with what they know, and many times might not have adequate understanding of mental health situations of people, but they are really committed and really desirous to help. When we look at outcomes, I think that a forum like this, which is a great opportunity, should be a forum that should include a lot of people that are leaders in the religious sphere, Christian, Muslims, traditional practitioners. At the same time, those people are not inclined to come to this kind of gatherings because, you see, the stigma of being associated with mental health involvement is not only for people, for victims. Sometimes the leaders themselves can be stigmatized for departing from the faith because they are accommodating all this talk about all of these things. So we do need to find a in terms of solutions, we need to find a way to bridge this gap of the education of our spiritual leaders so that from the get-go, it includes mental health education and mental health understanding. It will significantly help us. On the one hand, the education of leaders. On the other hand, because most, if not all of our people are engaged with some religious institutions, we have to ask the question, in the dissemination of mental health awareness.
You have 1 minute more, sir.
Thank you. Mental health awareness, we must consider religious institutions as channels of the deployment of solid mental health awareness across the country. I guarantee you, there is no village that does not have either a church or a mosque or a traditional healer. I believe that with their care, compassion, concern for all of the people of Nigeria, with their positioning in every part of Nigeria, and collaboration with people like Professor Sheikh and all of our luminaries that I've shared here, we could actually rule out a better mental health program and intervention across the country if we will partner with the religious community. I believe that that will be key to getting us to a better place with mental health. Thank you.
Thank you so much. Thank you so much, Reverend Austin. That was such a brilliant presentation about getting the religious institutions as outlets for mental health services. So without much ado, we would like to bring on our very next speaker. She is, okay, I'm trying to get her. She is the Honorable Commissioner for Kaduna State. All right, so, ma'am, can you signify so we can, so that I can spotlight her. All right, so, no, I won't, I'm just going to continue. Okay. Dr. Amina Mohammed Baloni, the Honorable Commissioner for Health in Kaduna State, is a medical practitioner who is a fellow of the West African College of Physicians. She also holds a master's degree in public health and has had over 20 years of practice as a clinician and then as a public health professional. Her core competencies in communication, drive for results, helped her to achieve results working with government across various states to improve health and well-being of children and women through capacity building and transferring technical skills such as planning, analytics, formulating strategies, and monitoring for results. Dr. Amina is a team player who leads by building consensus amongst a team, passionate about developing people, and a good listener. As a systems person, she believes that strong systems provide sustainable development and results. This lovely afternoon, Dr. Amina will be speaking on emerging innovations and adaptations using the Kaduna State Mental Health Initiative as an example. Please welcome with me Honorable Commissioner of Kaduna State, Dr. Amina Mohammed Baloni.
So a very good afternoon, morning, night, wherever you may be, to the distinguished panel, as well as distinguished participants in this forum. I for actually, we go back a long way. I will give mental health in Kaduna State, especially at the community level. So by way of background, Kaduna State currently has a population of about 9.1 million people. And of course, as with all our states, the majority of people are in rural areas. We have 23 local governments. And Kaduna State is known as a melting pot for all peoples. A lot of people have history with Kaduna. Some were born here, some went to school here, and some have long ties, which have remained to date. The health services in Kaduna is structured in such a way as the national, where you have primary health care at the local government level, secondary care, and tertiary care. And in those three domains, what has been happening is that you have a large number, most of the care is actually at tertiary level. Even though we have various policies that talk about having mental health streamlined within primary care, within secondary care, and within tertiary care. We have a number of tertiary institutions. Most of them are federal owned. We have the National Neuropsychiatric Center in Kaduna, which does the heavy lifting in mental health. But what are the common causes of mental health we have in the community? Of course, we have a lot of anxiety disorders, depression, substance abuse, which is rising, and its related disorders, schizophrenia, bipolar disorder, and dementia. And these conditions usually do not present to the health services, as I heard the last speaker say. In communities like we have cultural beliefs, strong stigma that is associated with mental challenges, ignorance of conditions, and simply sometimes people don't know where to go. And in those that actually are getting help, there's a lot of fatigue and among the patients themselves and even their supporters. And poverty sometimes is a barrier. So the policy background is that the federal government is trying to reform the mental health space. There is a national mental health policy that is aimed at providing adequate mental and neurological care for Nigerians, of health, integrating mental and neurological care into primary healthcare system, strengthening existing and developing systems, and decentralization of specialist mental and neurological health services. So what we have done in Kaduna is in 2014, we tried to adapt that to a mental health policy for Kaduna State. But unfortunately, we really haven't done much to actually implement that policy. Professor Sheikh has spoken about what work they've been doing, especially with the mental health scale-up in Nigeria, which was carried out in about 3 local governments. There's been a lot other bodies of work that have been done. Very good and innovative work has been done by the NIM Foundation among the IDPs in Borno, where they used the community members, the IDPs in camps were trained on simple counseling techniques. And when we listened to that story and we looked at what our primary healthcare is supposed to provide, which is the first step of recognizing mental illness, recognizing who needs to be counseled, who needs to be referred, and trying to establish in the secondary healthcare system specialist clinics where people can be sent up from the second primary care and then linked up to the tertiary care. And looking at those, the results, I'm sure you heard about it earlier, of what happened, is something that we can really do. We have a vast reserve of community health extension workers. We also have community volunteers, which if we do the adequate training and putting them through on what are the basic counseling techniques, how do you know if someone has mental illness and where do they go? And the second part of it is actually the work that should be done when you've actually taken someone with a chronic mental illness. He's under treatment. He needs to go back to the community. He can't remain in an institution. And this is where the failure is. People get discharged and there's no support systems, and very soon they relapse. If it is substance abuse, they go back to substance abuse. If it is an organic mental illness, they deteriorate because the conditions that were there in the first place have not changed. Another plank of what we're thinking of doing is how do we integrate the work that has been done in the adolescent and youth space. We have a lot of work being done with adolescents and youth, especially around HIV, and we have a very good network of youths. Some of them are youth corpers that are trained counselors. How do we get those resources that we have trained in counseling to understand, to take up some mental health issues and mental health counseling? And then we have the space. How do we engage the media? Following other programs that have successfully used media and successfully used figures, public figures, to really work and bring some awareness into this. Currently, we have an agency that has been established, which actually deals with substance abuse, and it's called the Kaduna State Bureau of Substance Abuse Prevention and Treatment. And this has focused on largely around the substance abuse space. There's been a lot of sensitization, a lot of community work. And the last speaker I heard alluded to the religious institutions having quote unquote homes where people that, as people believe, have either mental health challenges or they have substance abuse challenges, as kept there and hidden away from view. And like he said, some of them came to the news, especially in Kaduna, actually, last two years ago, a year and a half, 2 years ago, where large numbers of young people were found in these homes, shackled, in deplorable conditions, probably worsening their mental state and making sure that they're kept away from the drugs. So the answer is keep them away from whatever they're abusing, and then it will solve the problem. But then you have to let them back into the society. So we're looking at how do we integrate all this work that has been done in the space. How do we integrate the successes that we've had in other programs? And how do we make sure that from grassroots level, from community level, we reduce some of the ignorance and stigma around mental health and link them up to services, whether it's counseling services, and train our health, human resource for health at that level and at all levels to recognize how, what are the signs of mental illness, how they can help them, and how they can link them up to services to see that this is happening. So currently we're working with different organizations, with NEEM, who have expressed readiness to also do some work at community level. with a group that are in the States that also wanted to do that. Unfortunately, with COVID, we got a little bit derailed, but that is also highlighting a lot of the mental health challenges that has been happening in otherwise, shall I call them, normal people. And that's not meant in a bad way, to say that the effects of the uncertainty, of the lockdown, of loss of economic power, of confinement, of lack of interaction with others has really challenged a lot of people, and not the least, actually, even the health workers, because they've been confronted with a disease they don't understand. A lot of them have had to manage it. A lot of them have got it, and they also have been suffering from those challenges. So in a nutshell, what we're doing as an innovation in the mental health space is how do we harness what we already know and place them within the health system and the community to have an integrated mental health approach that starts from the community, goes to the primary health center, into the secondary health centers and the tertiary health centers. This is imperative because human resources for health are a challenge, and there's no more challenge, I'm sure, than even in the mental health space. There's simply not enough specialists, simply not enough people with expertise in that space, and simply not enough structures that have been put in place to do this linkage. We have to look for ways to make sure that this is carried along, and this is what we're doing while we're operationalizing the mental health policy of Kaduna State. Thank you very much.
Thank you so much. Thank you so much, Dr. Amina. We do recognize the great work that is being done there in Kaduna State. It's just beautiful. Thank you so much for all that you do. We want to see if we can bring back Madam Grace to see if she can complete her presentation very quickly. Mrs. Grace, are you there, please? Please, you have to unmute.
Share the screen again.
Okay, beautiful.
Is it possible to share the screen again? Sorry, it was just the internet.
We can't hear you.
Yeah. Okay. You can't hear me. Hello.
Can't hear you yet.
Yeah. Can you hear me now?
Okay, please unmute.
No, they can hear it. Off.
Okay.
Oh, you need to get off the phone.
See if I can.
Madam Grace, I think you're muted. Try to unmute yourself.
Please unmute now.
Hello?
Yes, we can hear you now.
Okay, they said they can hear me now. So I was talking on how does mental health affect persons with disability? Sorry for the internet, whatever, palaver. So having this disability can increase the risk of developing mental health. And research suggested that adults with disability encounter frequent mental health almost 5 times as often as adults that are not living with disability. And youths with disability can experience poor concentration, poor relationship, aggressive behavior, because they seem different, finding meaning about their life. Then they can experience behavior called irritability as well. Then parents of persons with disabilities can experience change in family dynamics and tiredness because of the caring responsibilities, lack of sleep. And research has said that when you have a child with disability or when you have disability, your chances of being separated or divorced is actually very high. And one of the things I would like to say is that poverty and mental health and disability, they are actually intertwined because of the stigma, the environmental factors such as social isolation, economic isolation. So person living with disability or a parent or a youth, the likelihood that they will have any form of livelihood is very less. So, and because people think they are very unproductive. When you are living with disability, they think you are unproductive. They think you don't have talent, you don't have skill. So that can increase the likelihood of getting mental health issues or mental health illness, which can result into panic attack, which can result into alcohol misuse, agitation, especially the youth or parents, drug misuse that can lead to drug misuse, food, they can be binging of food, they can have what we call bulimia nervosa or anorexia nervosa. So, and that statistics says that 80%, according to WHO, that 80% of persons living with disability are a person living with disability 80% of the world population. The world population is over 1 billion of people living with disability. So 80% of that, 80% of the world the population, according to WHO, are actually living with 80% are actually in developing countries are actually living with disability, and we have in Nigeria, according to World Health World Disability Report, we have almost about close to 30 million living with disability, and you can imagine how, I don't know where the services are, the services where people who are already having children with disability can be a kind of trauma, because I went through mental health issues, even though I had my son in England, because I realized that I've internalized, due to environmental factors, I've internalized disability, which is actually causing a lot of, like, I was like sleepless nights that can, and I was irritable, I was using different coping mechanism to cope, and sometimes the culture of silence as women too can actually affect the way we interact, the way we behave, and that can affect our mental health. So, and then poverty, lack of work, and if you have a child with disability, you have to get a kind of what I call something that will enable you to accommodate your caring role, and that can be difficult. So the fact that you start to find a kind of meaning in the way forward, that can cause a lot of stress for youth, for adults, for parents of children with disability. And also it's about the fact that they are, I would like to reiterate that they are actually linked. It cannot be separated. So when you are, especially where lack of services, and COVID has actually exacerbated those risks, in the sense that the lockdown, the pandemic, how many services are in Nigeria? Those lack of services, lack of information, lack of places where they can go to can also contribute to their mental health. And COVID has also actually shows that there is a miscarriage of justice in every, like, those children cannot go to schools, and when you have disability, where else, or when you have a child with disability, there is no respite where you can take those respite that they are very expensive. And considering the fact that poverty, because according to WHO says poverty, people with disability are the poorest of the poor. And that can also affect the way they reason, can affect their body, mind, and soul. And it affects their feelings. Some people have committed suicide because of the fact that they feel they are useless. The way they interpret the environmental factors, which are stigma. The stigma is serious. The stigma. When you when you have disability, and when you are constrained to be the best you can be, that is obviously will impact on your mind, in your thoughts, in your feelings. So this is really, 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 really serious. It's a serious issue. And I don't think in Nigeria, they understand that when you are disabled, you are effectively poor. When you are poor, when you are disabled, you are also going to face a lot of trauma. You start finding meaning into your life. So how do we go about it? It's about time Nigerian government strategize their laws. I don't know whether they've implemented it. How many, even with the COVID, how many people, what are the reasonable adjustments are they making for people that are living with disability? How is there reasonable adjustment that can enable them to function? Because one thing is that an idle mind is a devil's workshop. And do they actually understand that disability is a wide concept? What about the people with hidden disability? What about women that have been sexually abused due to lockdown, and the perpetrator are in the house, and the culture of that, and they cannot speak? So how are they rehabilitating those people? I've done a video on people from grassroots. They are the most people that are actually affected so much. How are they having the services to like trauma-informed care? How are they exposed to services that can enable them to function again as a human being? How are they being rehabilitated? Even in a workplace, you are going to face a lot of discrimination if you are having a...
One more minute, ma'am. You have 1 more minute, ma'am.
So this should be looked into. This should be looked into. It's a serious issue. If you have 30 million of people, close to 30 million people living with disability, there is a big deal for either parents raising children with disability, for youths who, because of peer pressure, because of the fact that how the stigma, the myths, the taboo that, oh, it's one family, or it's your, even the cultural, in religion circle, where they think, oh, it's your son, it's your sin of your great grandfather that has caused your disability. All this, we have to give it a holistic approach where we can deal with people so that they can start living a normal life, so that we can improve their life chances as human beings. Whatever, no matter how complex a disability is, one thing is foremost: you're a human being. And I know from experience as running an international organization, as a mother, I know, and thank God for England, because I've been exposed to a lot of services that enable me in my caring responsibility. And I know a lot of youths who have been exposed to a lot of opportunities that can enable them to function. So what about the etiquette? A lot of things are actually going on. In Nigeria, I don't think they understand the concept of disability. That is a big deal. It's a big deal. The way the society perceive you can have a serious impact on their mental health. So it's high time we start going around the table, start talking. Let's get the conversation and let's start the conversation. Let's start making sure that no one is excluded. No one is left behind, especially our women and youth living with disability. In fact, they've internalized it. I will say that. After living in England for 28 years, when I had my son, my last son is 26, and I realized that I internalized. So I have to go through trauma. I have to go through a lot of things so that my eyes can be open to the reality of and that can
Mrs.
happen.
Grace Alexander, we can't hear you the last part. Oh, okay. Thank you so much. Thank you so much. What a great presentation. We really appreciate just enlightening us about people who work and walk around day to day with disability. This conversation will not be complete without having this information. So I hope you can stay till the end so we can, in case there are questions. Thank you.
Okay, that's fine. Thank you very much.
Thank you so very much, Ma. We really appreciate your insight into this. We're bringing on our next speaker. We're bringing on our next speaker, who is a clinical psychologist and psychotherapist, Dr. Olugbemi Olukolade is the National Secretary of the National Association of Clinical Psychologists, NACP. Okay, so sorry, I apologize. I've just been told that the Honorable Commissioner for Ekiti State is in the house. So I would like to bring him on right now. Dr.
Hello, good afternoon, everyone. I hope you can hear me.
All right, so we will be bringing on next the Honorable Commissioner for Health, Ekiti State, Dr. Oyebanji Filani.
Good
Dr.
afternoon. Can you hear me?
Filani is a trained physician and health economist, working with working experience in the United Kingdom and Nigeria. He has 14 years in public health financing, resource mobilization, pooling, and strategic purchasing, program execution, health strategy, and social development. He serves as the technical director of the Basic Healthcare Provision Fund, the largest healthcare reform initiative in sub-Saharan Africa, with the potential to provide universal coverage for over 100 million Nigerians. The BHCPF creates additional fiscal space for the health sector, equivalent of $12 per capita, and is funded from 1% of the federal government of Nigeria's annual revenue. Dr. Filani this afternoon will be discussing with us commissioning services for outcomes, not outputs. Ladies and gentlemen, please welcome with me Dr. Oyebanji Filani.
Good afternoon, everyone. Just to confirm, can you hear me and or see me?
We can't hear you yet. Okay.
Fantastic. All right. Thank you very much for inviting me to join this very esteemed set of panelists. I must also thank Professor Marino. We've had conversations over the last 2 or 3 months, and we should ideally have met, but unfortunately, we've not been able to do so. I really do hope we can speak on phone before you go back to the States. I will try to take this very quickly. I think it's a germane topic, and it's interesting that I've been asked to speak on this. I don't know if my slides are up, and so if people can see that. Otherwise, I will just continue.
Give me a minute.
Whilst the slides are coming up, I think I can take advantage of the time. I joined the administration of His Excellency Dr. John Kayode Fayemi the 31st of August 2020. So it's just about 5 or 6 months since I came in as the Commissioner for Health here in Ekiti. One of the very first things that stood out for me when I came in was having visited about 50% of our secondary care facilities and a host of our primary care facilities in the States. It was very clear that for everyone I had asked what the major issues were, the conversation or the feedback was always, we don't have enough healthcare workers, or we don't have enough tools, or we don't have enough equipment. And I remember one particular facility that I visited that had about 30 nurses in the facility. So I asked the head of nurse as usually, and I asked, look, what are your biggest challenges? And she said, no, we don't have enough nurses. So I looked at the outpatient register in that facility and realized that the average over the last 2 years on a monthly basis in terms of patients seen outpatient was about 300. And so if you do the rough math, 300 divided by 30 gives you about just a patient per day per person per nurse. And so my question to them was, well, you're not seeing as many people. How do we justify having more inputs, right, and not getting any sort of value from it? The point I'm trying to make is more often than not, and which is the slide that you're looking at here, more often than not, we typically follow, take a look at service delivery from, the inputs perspective, which is the yellow upper bar, the inputs, right? So what do we need? We need more health workers. What do we need? We need more ambulances. What do we need? We need more facilities or more hospitals or more tools. Well, if you take a look at the entire space, you have your inputs, you have the activities that ideally should come out from there. You have what you call the outputs, that is the volume of work done. Then you have the outcomes, and down the line, you have the impact. Typically, most people will focus either on the input or say, oh, I've been able to fill 50 of the forms, right, as sort of like their output. In Ekiti, what we are doing and our key focus, right, is to change the currency, right, the language and the currency and the narrative around our core objectives in the state, from the inputs to service delivery or the output, right, to the outcomes that matter the most. And here in Ekiti, it's simple, is to ensure that we can prevent it's to ensure that we can prevent as many deaths as possible in the facilities, right, whilst at the same time increasing productivity in the facilities. So our goal is to move away from what we currently see in the logical framework, where people focus either on the resources dedicated to the project or the actions or activities that need to be done or the volume of work, to the benefits of all of that to the patients after the project and the long-term consequences, because there's a clear link between health and the economy and economic growth, right? And you would see on my next slide how we decided to do that. So very early on, after meeting with all the players and stakeholders in the space and visiting the facilities, we decided to put together like a program to redefine our service definition in the state. We had a joint review of the current performance by all stakeholders. We had an exhaustive definition of the inherent challenges and a synthesis of what we call like the major issues. And I decided that it was important that we strategically planned for a future state that enabled us to link, outcomes with available resources. So our resources will not just focus on, yes, we've provided more facilities or we've provided more healthcare workers. It is, at the end of the day, what does that amount to? How many of those healthcare workers or how many of these facilities have helped us to reduce deaths in the facility, or also helped us to improve the quality of care that is received in the facility? So very early on in September last year, we had a 3-day retreat with all our partners, where we're able to highlight what the main challenges were in the state, and also just then focus on an opportunity to co-create a program that begins to change the narrative from a logical link from the contributions, right, into the inputs to the desired results that we want to achieve in the state. And I think for us, the big thing is a significant reduction in preventable facility deaths, and enabled by an improved quality of care program in the state. The advantage, of course, for this is we having the ability to put together everybody ensures that we're able to generate additional resources because we had our partners involved, but also to ensure better cooperation across the multi and very diverse stakeholders that we typically have in the health sector, not just within the public sector, i.e. your HIV agency, the SACAs or the SPHCDs or the insurance, but also within the CSO community, the development partner community, and also the general citizens. On my next slide, you will then see how, just going back to the first slide that we put, is how we are rejigging it, right? And again, like I mentioned, our focus in Ekiti is very clear. The currency, the language here has moved away from we need to build more facilities, or we need to have more doctors, or we need to have more equipment. It is how do all of this help us to achieve an improvement in the quality of care, right, that is being delivered, and how do we ensure that we can reduce mortalities and facility preventable deaths. To do that, of course, we're entrenching a very strong governance and performance management cycle in the state. Just last week, we set up the committee for our quality of care in the States to focus on three key things. The first is around what we consider quality assurance, and that would enable us to set up an institution for standardization and accreditation of all healthcare providers in the States. The second is on the quality improvement, a continuous quality improvement. And that is important because whilst an institution that focuses on quality assurance gives a snapshot, we also want to be able to provide the capacity, the skills, and the tools for people who work in these facilities to continuously think about what they need to do to ensure that they can improve the quality of care, and not necessarily focus all the time on, oh, we don't have the money, but within the resources and the human capacity that we have at the facility, how do we constantly improve on what needs to be done? The third part of it is also ensuring that we have a policy in place. So we're confident that within the next, by the end of April, we should have all of this fully sorted. And we've already started, particularly on the continuous quality improvement in 3 local governments in the states here. So yes, you would still need the financial resources. Yes, you will still need the human resources. Yes, it's important that we introduce, we upgrade the facilities, but we have to redefine our measures of success, moving away from how many people we've tested or how many facilities have been built to saying how many of those really did get the right set of care, the quality of care that should be available to them at whatever level of facility they go to, and come out of it at the end of the day as a better people. So if you look at my next slide, essentially you see how the typical report is done, and that's the one where I crossed out in red. You would see the typical previous report will say we've upgraded physical structures and equipment of
You are muted, sir. Please, can you unmute? Yeah, will not be able to unmute because we can't. Please unmute yourself, sir. He can't hear us.
That means people look at an elephant from different perspectives. You see the tail, then all you talk about is the tail. If you're looking at the tusk, all you talk about is it's an ivory tusk. But if people zoom out and see the entire elephant, then they understand how best all of the different things fit in. So for us is let's improve quality of care at facilities as a recommended report format. And then there's specific things that need to be done around those areas. Let's improve emergency preparedness and response. There's specific things to be done around those areas. Let's entrench a strong governance and performance management structure. There's specific things to be done around those areas. And all of this must and should link to better health outcomes in the state. I think just to link it up with some of the other things that my colleagues have or the presenters have made is also as a state, right, is to recognize that particularly with COVID and the challenges we've had, there's been a subtle but much higher linkage with mental health issues around this period, higher rates of abuse or depression, right? And so for us as a state, it is important that we look at mental health in a more holistic manner and ensure that we can integrate this into our primary healthcare system. And our lesson is simple, is to ensure that let's avoid reporting in isolation. Let's embed all issues within a broader context to enable people to understand the drivers for change. And of course, continue to reiterate the strategic results that are linkable to outcomes and clarity on the sort of understanding of the different pieces. On my last slide, it's a summary of what we've done so far in the States and how we're changing the narrative around service delivery and ensuring that people focus on outcomes and not on inputs or outputs. And so the first thing we did was to review and co-create with relevant stakeholders and communicate the narratives in a manner that is logically feasible and that they understand our inputs that they've either thought were the final points should help them to achieve a broader set of outcomes. The second was to start from the end goal and design programs based on that. So we wouldn't design because, we need to we need to procure X number of long-lasting insecticide nets. No, but there's a rationale for doing that is to ensure that we have less people who fall ill. And so once you start from that, then it's easy to then align and address your goals for a desired change. The third point is to avoid reporting in isolation. and to embed them in a broader context that enables everybody, whether the health attendant in the facility or a director here in the Ministry of Health, or even within the State Executive Council, understand the key drivers for change. Thank you very much.
Thank you so much for that. We are so grateful that you're sharing what's happening in Ekiti State. And I do hope that we get to actually have a conversation before I leave. There's so many wonderful things. Thank you for that great presentation, Honorable Commissioner Filani. Thank you so much. And hopefully, I don't know if you can maybe come back at some point after your meeting, because we have a panel, if that, and we'll move on to, because I know you have a meeting now, so we'll move on to the next guest. And Binke will take over.
Okay, thank you. Thank you so much, Dr. Marino. Right now, we will be moving on to our next speaker, and that is Dr. Olukolade. Olukolade is representing the National Association of Clinical Psychologists. Yes, he is the National Secretary, National Association of Clinical Psychologists, NACP. He is a psychotherapist who is a strong believer in the use of psychological theories to help people. He began his career in the mental health field in 2006 at the Department of Psychology, University of Ibadan, where he obtained his master's in clinical psychology. He has more than 9 years professional experience in providing psychotherapy for different illnesses. His expertise in cognitive behavioral therapy, exposure therapy, behavioral family therapy, couple therapy, and sex therapy. He has exquisite experience in conducting various tests, especially intelligence tests. He has a strong bias for neuropsychological assessments and recently developed cognitive rehabilitation protocol for post-stroke survivors. Dr. Olukolade employs a workable and solution-based approach to life issues, leading to opportunities in seemingly difficult situations. He has interest in treating children and adults with various disabilities and disorders such as insomnia, learning disorders, memory, mood, anxiety, and sexual dysfunctions, and also marital problems and conflicts. He is an avid motivational speaker and a life coach, and we are so pleased and excited to have him here to discuss how we can leverage the disruption and negative effects of COVID-19 pandemic for positive and sustainable reform. Ladies and gentlemen, please welcome with me Dr. Olugbemi Olukolade. Sir, please, can you unmute yourself now, please? Okay.
Thank you very much for
All right. Over to you, sir, for your presentation.
Yeah, thank you. Thank you so much for the invite for us, clinical psychologists, to present at the conference. It's an opportunity to be here, and also greetings from the National Association and the executive. I will be briefly talking about how can we leverage on the disruption and negative effects of COVID-19 pandemic for positive, sustainable reform. Now, of course, as we have already known before, contagious diseases can have disturbing effects on living things, irrespective, not only human beings. And humans, as we have, are also not exceptions to the serious disruptions that come from COVID-19 due to the stop to things that we tag as our normal activities in the past. COVID-19, like all of us must have known, is an infectious disease that is caused by a new strain of coronavirus family, the SARS-CoV-2. And the virus, as we know, belongs to the same family of SARS-CoV-1, which was responsible for the severe acute respiratory syndrome, SARS pandemic of, well, not pandemic, but the one that happened in 2003. This particular episode started in Wuhan, China, and from a food market, probably, and which was in late 2019. And since that time, and it became very bad in the year 2020. This particular coronavirus seems to spread a little bit faster than the other COVID-1, and has affected nearly, according to WHO, has affected nearly about 213 countries with more than 40 million cases that have been recorded, with almost 1 million deaths. Besides the effects on public health that we've had for back the COVID-19, we've had other significant consequences that it has had on our lives. And one of the disruptions that it has had is especially on it has a serious economic impact. And the economic impact definitely affects the way we live our lives. It reduces activities, it reduces the gains that people do have even in their social functioning, which in a way affects our social life and even the psychological nature of our lives. Now, all over, in terms of history, infectious diseases are critical events, and the risk and the effect of such maladies present enormous challenges to the society, irrespective of the unit of the society that is affecting, whether it is family, whether it's community, whether it's culture, whether it's the country or the regional relationships that we have between countries. And this oftentimes challenges us to start introducing temporary or even more long-term changes to our thinking, to our way of doing things, and even to our lives generally. The pandemic dimension of this particular coronavirus further exacerbates the fact that the risk to the society seems to be enormous, and highlights the importance of one of the first things that it highlights is for us to understand that we need preparedness in meeting challenges of potential impacts such as this, and in taking correct actions, especially in nations like ours, Nigeria, for us to have to not just to prepare for pandemic, but for us to put things that are first, that are supposed to be first things, to put them as first. And making first things that are supposed to be first is that making our health facilities prepared, such as having the right equipment, not just on paper, but rather in actual fact. Then also to totally train our people about what they are supposed to do. Of course, of what to use equipment without ability to use them to their optimal use. It's just like having an iPhone that can actually make musical videos for only making calls and sending text messages. Then it makes mockery of the value and the depth of what it can actually do. Then also it talks another thing that is that because of the coronavirus, what's actually happening concerning the coronavirus, one of the things also that is important is that we have to start looking at the solutions that can control the transmission of the effects of the disease, like COVID-19, which are undertaken mainly, and these have been mainly done in terms of healthcare systems, engaging society in different behavioral actions, which has a lot of psychological background, because related behaviors, health behaviors are of about our perception and the way that we think about such illnesses. For example, a lot of religious and cultural beliefs come with the fact that coronavirus could actually have been a way of a is a kind of attack on the on Black people, on specific nations, which unfortunately is not true. And some such actions of like behavioral actions, such as hygiene measures or social distancing, sometimes have been looked away from. And at a point, we saw a lot of videos of people from some parts of the country that were saying that it's actually absolutely not true. And they see them washing their hands and saying that they are going to wash their hands, and they drink the water and things like that. It tells you about the psychological mindset about people, and that makes us to start saying that one of the reasons why a lot of programs that we had in the past have not worked is because many times the focus of our actions are much more on the health system and the walls, rather than even the mindset and looking deeply into the perception and the attitude of people into in taking health, in having health-seeking behavior. And the question then is that, are we looking at this holistically? What about the whole other areas of health that have been impacted by the virus, such that our mental health? That the question is, are we paying enough attention to our mental health, and what about not leaving anyone behind, especially in the accessibility of people to to mental health services before COVID-19. And studies have actually shown consistently now that the number of people who have either they have resultant mental health or they have mental health situation prior to COVID-19, which were unattended to and currently presenting, increased significantly. In the past, certain infections such as cholera had influenced and changed the previous way of our thinking. For example, there are different ways that we start accessing health and seeing our environment, even in the designing of our hospital, in the designing of our home, on the access even to treatment, and the development of urban facilities and the world at large. Now, and if we leave out conspiracy theories, we'll be able to say that we have not reached even the point where we start looking at the model holistically, and that is the one that combines the biological, the psychological, and the social model without holding one higher than the other. Because in all fairness, the coronavirus has actually made us to see that we are not supposed to look at treatment of our health as a whole from the aspect of finding cure alone, but we have to look at it from the removal of distress from our lives. And this is the coronavirus induced pause in our lives has given us a big chance for developing more sustainable systems for dealing with our body, especially our mental health. And in truth, there is a challenge that is ahead. And in the short-term implications of this coronavirus and the global challenge are evident everywhere. But on the long-term consequences, how will it reshape our health and developing institutions, occupations, and priorities? We are still saying, and I'm sure that a lot of things will still come out from this. One of the first areas that I will talk about massive sparks in investments. One of the things, the leveraging, the negative effect is of course that people have to there seems to be a opening of our eyes to see that there is something wrong in our emphasis of investment. So one of the things that we can leverage on talks about massive sparks of investment. The outcry in virtually every country of the world talks about, and especially in our country, talks about lack of equipment and supplies to test for and protect against COVID-19, which had led a lot of countries to re-examine their chain of supply for critical health and livelihood-related products. And of course, in our country, recently we discovered that Nigeria started producing face masks and also hand sanitizers. And this is massive spark of investment, because it's, the leverage that we have is that countries need to start thinking that getting our things that we use, even in our critical health care products, have to come from outside of our shores, because countries have been forced due to the cost of importation and even the barriers of importation at a point that countries traditionally who have no capability, such as ours, have realized that there's economic impact of this pandemic. And because of that, they have to look inward in opening up investments in areas of health. And also, there is one of the things another thing that is important that this has caused is excuse for isolationism. And the pandemic right now, as we could see, is a new excuse for nationalism.
Yes, sir, you have 1 minute more, please.
All right. So then also there is emerging mental health impact. Like many other countries, there is current health crisis and the emerging problems of mental health. One of the major important leveraging that we can actually use at this time is to open up our mental health space by having primary healthcare centers that can provide mental health services rather than primary healthcare centers that are much more for cuts and burns. But really, we have to actually do that. And that's one of the things that we can leverage on. And finally, I'll talk about accelerating technological uptake. Now, one of the things that this has done for us is to open up our technological space. And the COVID-19 has actually made us to accept even the use of technology in terms of triaging, in terms of helping us to even see patients in sharing critical guidance and providing emotional support. And there is need, indeed, more to ask, to learn and to relearn, especially in providing effective and acceptable psychological health, testing and assessment, using technologically based service platforms. Indeed, it can only get better. And as the saying goes, you can't put the genie back into the bottle once deployed. And the use of these technologies will only expand over time. Like now, the use of Zoom and other major Google Meet have shown us how mental health practitioners can be talking about too few health personnel or inadequate budget or weak health systems in approaching and helping people to overcome psychological issues. Thank you very much for the opportunity to talk to the audience.
Thank you so much. Thank you so much, Dr. Olukolade. Our belief is that with this point that you have raised, we will be able to actually look at sustainable reforms as a result of the COVID-19 disruption that is facing us here. Without much ado, I would like to move on to our next speaker. Would like to bring up our very wonderful moderator who did a wonderful job earlier on in the morning, Tolushe, the mentalist. Is he muted? Okay. So, Tolushe, the mentalist Francis, is a mental health educator. He has been a consistent champion for mental health and workplace wellness in Nigeria. As a mental health educator, he is constantly educating people across the world through his courses, which till date has over 14,000 enrollments. YouTube tagged The Mentalist and podcast, The Rising Heroes podcast. He is also the convener of a yearly event tagged Breaking the Habit Code, where he helps individuals break habits that hinder them from being their very best. Right here in precious Nigeria, Tolushe has been on radio and television programs such as Be All You Can Be, Seriously Speaking with Adesua, Robin Minds, just to mention a few. He hosts a weekly show tagged Rise Above It, targeted at workplace mental health in order to create awareness around workplace wellness. On the international scale, Tolushe is a board director at the World Federation for Mental Health and was recently recognized as one of the most influential people of African descent, class of 2020, in the health and medical category. Tolushe is a 2017 Yarly RLC Fellow. He is an author, writer, who also reviews articles and writes in journals of mental health interest. Today, Tolushe will be speaking on the role of training in the mental health space. Everyone, ladies and gentlemen, please welcome with me Tolushe Doe, the mentalist Francis.
Thank you for the introduction, Adebimpe. I hope you can all hear me.
Yes,
it's an honor to be here. All right, so the place of training in mental health cannot be overemphasized. It's often said that knowledge is power, but you see, of what use is having knowledge and having the power and you don't make use of it? And how do you even acquire this knowledge? You don't acquire knowledge by just lying down on the couch and hoping and trusting that you would know something. It requires that you take actions and that you make a decision to actually know these things. Maybe I would love to use my story this afternoon to drive home the importance of training. When I was to get into the tertiary institution, I wanted to study medicine and I wanted to specialize in oncology. And after waiting for, I think about 3 years and medicine wasn't forthcoming, I finally accepted admission to attend a particular school with the hope that I was going to be offered medicine. And then in my second year, medicine wasn't forthcoming and I didn't want to go back to write JAMB again. So I continued. And I continued because I thought that, okay, by the time I'm done, I'll go back to school and continue medicine. Well, this is over 6 years since I graduated. I'm yet to go back to school to study medicine. But what happened? Again, I'll backtrack. In 2005, I lost my mother to cancer of the liver. And just when it was clocking 1 year, I lost my paternal grandmother to cancer of the ovary. Now, these two events changed my life completely. I didn't know. But I remember that I became a very quiet person. I became a very reserved person. I used to be a young chap, bubbling. I would greet everybody on the road, read every signboard on the road. You know, that sometimes my late mom would even say, do you have to greet everybody that you meet on the road, you know, and all that. So, but I realized that between 2005 and 2013, that changed completely. So one day I got back from work in 2013. I was living with a friend who happens to be a psychiatrist. And he asked me one question, Tulusha, how are you? I said, I'm fine. He said, no, you are not. And I asked him why. He said, because each time you get back from work, you don't shut down. As soon as you just greet us, good evening, you get back into your room and you lock yourself up. And the next time we see you is the next morning. And it's dawned on me that for that period of years, that's about 8 years, I had actually become a completely changed person. And then after much work together with me, helping me through, realize that I've actually been dealing with depression and grief. And, you know, it took me through therapy, and that was where my spark for mental health started. Now, at that point, there was a craving or a rage of weight loss. So I became interested in eating disorders. So I decided to enroll for courses that were going to make me knowledgeable in the aspect of these eating disorders. The best way to learn when you want to learn is to ask yourself questions. Why? How? What? Right? I began to ask myself, why do people eat to the point that they lose, that they add weight, not talk of losing weight and all that and all that. But then I realized that it was beyond losing weight, that there were other fundamental issues. I tried to study mental health at a diploma level, but I wasn't satisfied. And then I realized that my experience losing my mother and my paternal grandmother took me on a journey of grief and loss that I didn't even know I was experiencing. So I became interested in grief therapy and grief counseling. So I started learning about that too, took courses, NLP, life coaching, and all that. But along the line, I realized that, look, it's not just enough to be an advocate. It's also important that, I mean, we have a lot of advocates, which is good, very important. But where do these people go to after all the talks? Where do they go to when they have listened to the motivation and the encouragement, right? They need someone to go back to. So I became very interested in grief counseling, and that began the genesis of my getting trained and all that. But you see, it's not enough to just have someone that can go to. I believe that everyone on the surface of the earth should be able to hold basic mental health conversations. Everyone, every living being should be able to hold conversations as simple as, what is mental health? Why does my mental health matter? Differentiating between mental health and mental illness. And to encourage people to learn as much as they can learn. When Enaro was speaking the other time, he talked about the intersection of life coaching and mental health therapy and all that. And the truth of the matter is, irrespective of your profession, irrespective of the job that you do, you have someone within your office space, within your workspace, who needs to hear something that has to do with mental health. You have someone who is not speaking up, but if you have a knowledge of mental health, you're able to decipher why this person is just quiet and all reserved. why this person isn't speaking, or why this person is behaving the way he or she is. And you see, these trainings, these learnings don't have to be sophisticated. We need to move away from that point where all that we desire is the certificate. But let's move to that point where all that we desire is the knowledge. And with this knowledge comes power. Now, imagine that you have energy that is stored within you. Of what use is that energy if it's not flowing through? Of what use is what you know if you're not teaching others or informing others? And so I want to charge each and every one of us listening today that this symposium will not just be a place where you have come to learn and to listen, but I will go out there as well and teach others what you have learned. And that was what led me to begin, that was what led to the creation of courses that I have on Udemy specifically, that I created because I believe that simplifying some of these things that look very huge or very big for the common man. So I use the word common man with all sense of respect, but that person on the street who doesn't have any background in science at all, that welder on the road, how do you discuss mental health with such a person? I gave a talk at TEDx Oshogbo sometime, I think 2 or 3 years ago, titled Mental Health and the Concept of Ashiwere. Now, there is something in Yoruba that says that it's easier to look at in quote, a mad person. I use the quote because it's a derogatory word, but it's the way it's been said, that it's easier to look at a mad person than to have such a person as a child. And so you see, everybody wants to look at a mentally ill person on the road, demonstrating and all that, but nobody really desires to have such a person. But what step are you taking as an individual to educate people around you as far as mental health is concerned? Or do you belong to that category of people that you believe that mental health has a spiritual, mental illness is rather has spiritual connotations? Or do you belong to that class? We still have people who still believe that whatever happens to you is because you have offended the gods, you have offended someone and all that. It is my hope that Africa, Nigeria in specific, can come to that point where everyone knows at least something that has to do with mental health, something that has to do with mental illness, something that has to do with psychosocial well-being, that we understand that our mental well-being is a critical part of our physical well-being. And that's why I love the fact that, I can't remember who spoke now, okay, the doctor from Ogun State, Dr. Adebowale, where he said, one of the things that they have infused into some primary health care centers in Ogun State is to do mental health evaluations. I think that at a primary health care level, or any of the levels, when you go to the hospital, while they are taking your vital signs, one of the questions that they should look out for is to ask you, how are you feeling? Not in terms of how you're feeling in terms of physical health and strength, but how are you feeling internally? When someone walks to your station as a nurse, as a doctor, and you're having your consultations, could you please just ask, how are you feeling internally? What do you think about this thing that is happening to you? How is it affecting you? Because if a person is diagnosed with malaria and you give that person the drugs, it takes that person to believe that the drugs will work for the drugs to actually work. If I don't believe that the medication that you have given to me is going to be effective, nothing would happen. And so no matter how much injections and medications, tablets, capsules, caplets you give to that person, if there's any sense of doubt within that person, nothing would happen. And so I would wrap up by saying that the human mind functions in 3 categories. There is a thinking, a feeling, and a behavior. What I think is happening to me would result to a feeling, and how I feel will result to how I'm going to behave. So we need to create a generation of people who think positive, who think that things can change for them, who are not just adamant, and who don't see mental health or mental illness from the standpoint of an illness of the rich, or from the standpoint of religious damnation, but that begin to think about it from the angle of, if I can be down with malaria, if I can be down with headache, fever, then it's also possible for my psychosocial well-being to be tampered with or to be hampered. And with that thought, they come to a point of feel where they feel that, look, I have a role to play in ensuring that I guard and I manage the things that I take in and the things that I allow people to say to me. And with that, they begin to act out in a way that they are deliberate about what they read, what they see, what they listen to, and what they allow people plant into them. So I charge us today. I don't know how far you have gone, but I want each and every one of us to go back and ask yourself, what can I do to contribute to mental health education in Nigeria? What can I do to contribute to mental health literacy in Nigeria? What can I do to contribute to the knowledge gap in Nigeria? And that led me to creating my YouTube channel, where I try as much as possible to educate people on topics as regards mental health. My podcast, same thing, which is more tied towards encouraging and talking to people how they can move from one place to the other. That's called Rising Heroes. That you may be down now, but you can actually be up. And I hope that at the end of this symposium, we'll be able to tell ourselves that it's not just the mental health professionals who have a responsibility of educating others, but each and every one of us, as long as we have breath in us, should be able to educate other persons. Thank you.
Thank you so much. Thank you so much. Thank you, the mentalist. And we join you in looking forward to that. While you were talking, something just came up that we are indeed looking forward to such a time that our organizations will in fact become trauma-aware organizations, mental health knowledge-aware organizations, to such a point that it actually becomes a thing of policy. And you are really doing great work with your YouTube podcast. So thank you so much for that presentation. Right now, we're going on to our next speaker, Coach K. Coach K, that is who we have coming up next. Coach K, please, can you indicate so that we know that you are okay? Beautiful. I've seen you. And then thank you so much for your patience. We're right towards the end. We're looking forward to Madam Eitayo's presentation and Dr. Merino's presentation as well. Thank you so much. All right. Kemi Oyeshola, aka Coach K, as we popularly know her, helps senior female corporate executives aspiring for C-suite and board to get promoted. She has helped many of her clients get promoted within 3 months of working with her. She is the creator of over 13 online courses on the innovative art of how to think, an author of over 7 books, having written her first book in just 5 days. Coach Kemi is powerful and an impactful speaker who declares truth with boldness and clarity as she goes on her mission of bringing back the lost art of credible thinking. Kemi is a Cranfield doctoral researcher who occupies her time with legacy building, touching hearts, and making a difference. As a certified trauma care specialist, she also holds BSc honors and a BA honors degree. Numerous certifications, amongst which are Power Change Gold Coach and NLP practitioner. She is the founder and director of How to Think Global Consulting and How to Think for Young People. This afternoon, Coach Kemi will be discussing with us the provision of effective services among mental health coaches. Please join me this afternoon as we welcome Kemi Coach K Oyesola. Thank you. Please unmute yourself. Thank you.
All right, I'm unmuted. So it's because I don't put dots under the S and the O, but it's Oyeshola. So thank you so much for having me, Dr. Merino. I'm going to jump straight into it because I'm timing myself to do 10 minutes. I'm going to share my screen and let me know if you can see it. And I hope it's the right one. No, it's the wrong one. So I'm going to stop the share and share my screen again. And I hope this is the right one because I need all my slides showing. So, I'll stop the share again. Bear with me, please. And we are going to go back. That was the right one, the first one. Okay, so that's what I'm going to talk about, and I just need to move this aside. Behavioral Mental Health Summit, thank you so much for having me. The provision of effective services among mental health coaches. And then we're going to look at some definitions, and then I'm going to give you just about 5 steps that I think we should take to determine that title. The provision of effective services among mental health coaches. So we'll look at a few definitions for now. The WHO definition is state, and I want you to take note of that word, a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her or his community. Now, there are a few definitions here I picked up from a few speakers. State of the mind. It's biopsychosocial. It's a physical, mental, sociological, psychological well-being. That is mental health. Mental health. The opposite of mental health is mental ill health. So let's keep that clear. Now, I'm going to look at the word provision because that's in the title, the provision of effective services. The title, according to the dictionary, Cambridge Online Dictionary, to provide means to give someone something that they need. Or provision is the act of providing something. So to give someone something that they need. So we are not going to give them, provision is not giving them something they do not need. That is not provision. Something they need, the act of providing something they need. That is meaning. Now, to be effective, and all these slides you see I took from Google. The dictionary meaning of effective means successful in producing a desired or intended result. Successful is important that you're successful. If you're not successful and you're producing an intended or desired result, you are not producing it. So you are not providing the care that you have set out to provide. Another meaning is successful or achieving the results that you want. So you start with the result, the end in mind. You start with the result and you say, okay, this is where we are going and these are the steps. That is being effective. And so let's look at the meaning of service. There are different ways you can serve. You can support, you can be responsible, help, assistance, guide, solution, and care. Just look at the spelling of solution. I didn't see solution. And come on, let's get it right from Google. Oh my goodness. Anyway, I had to do that. So let's look at the meaning of the word service. Service, a government system or private organization that is responsible for a particular type of activity, in this case, mental health. That's our activity. Or for providing a particular thing that people need. People need it, and our particular thing is providing mental health. So we could support them, we could be responsible for them. That service, we could care for them, help them, assist them, guide them, bring a solution to their mental ill health state or whatever it is when it comes to mental ill health. Now, there are different ways of being effective. So I want you to look at these synonyms. When you're effective, you are active. So I want you to really keep these things in mind. You are active, you're adequate, you're capable, you're competent, you're effectual, you're efficacious, you're efficient, you're fruitful, you are helpful, fruitful, you are helpful, you are operative, you are potent. That is critical. You are productive, you're serviceable, you are successful. Do you see these words keep coming up? You are useful. Being effective means you are useful and you are valuable. Now, this is the difference between effective and efficient. So efficient means you're doing the things right. Anybody can do the things right, but are you doing the right things? So doing the things right is I need a chair to sit down. It's a chair because I need to be at the dining table. Or you bring me a stool. You brought me something to sit on. You are efficient, but you have not been effective. So you can be efficient without being effective. And we want to be effective in Nigeria. This is another picture of being effective. Everyone is pushing something forward, and that's what they're supposed to do. But the square ones are much slower. But the one that can roll, so we need to think about how things work and work them. So look at this definition by James Allen, paraphrase. The effort you put into thinking determines the measure of results you get. the thing that humans don't like to do, they do not like to apply effort. They just want alakazam. In Nigeria, is prayer, 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 speaking in tongues, just go and give money in church, pray, pray, do fasting. It does not work like that. You are given a brain to use. You are meant to use it. There is a place for prayer, but I promise you, prayer works with your brain. You see, it's like faith. Faith without works is dead. I say faith without works is a corpse. You can have all the faith. Hey, God will do it. God will not do it. God, if you're upset, I can only apologize. But God will not do it because there's a part you play that He will not play. So let's move on. Read that again. The effort you put into thinking determines the measure of results. So I have 2 more slides. So time which you cannot get, time which you can never get back. So time is more important than money. Don't spend your time running after money. Spend, did you hear that? Spend your time. Time plus effort, just thinking is like, and I always say to my clients, think to solution. Think what you want, not what you don't want. Thinking what you don't want is being negative. That's negative thinking. Because the simple meaning of negative means the absence of. So you want cure, and you're thinking, hey, I don't have money. I don't think I'll get it. You are thinking the absence of something. And once you think it, you will get it. Because there's a simple principle. As a man thinks in his heart, so is he. So you're going to get what you don't want. Then why are you thinking what you don't want? Apply their hey, whichever, then we are in Nigeria. That is a sentence that should be buried. It should be in the grave. The grave should be growing molds and by now. Because we are in Nigeria, we put ourselves down with our own mouths. Why? Because that's what we are thinking. And out of the abundance of our heart, where you think in your heart, the words will come. So use the time. You only have 24 hours in a day. You don't have more. So when you say it's been a long day, it's never been longer than 24 hours. But time plus effort is what will give us success. So we need to apply that to what we're doing. So I want to remind you again, the effort you put into thinking determines the measure of results you get. So the 5 things I think we need to do is we need to lead with integrity. Integrity comes from the word integer. Integer means one. What you are saying, what you are doing, how you're walking, how you behave should be one. Don't say one thing and do another and then tell me we are in Nigeria. I want to slap people for breakfast, lunch, and dinner when I hear that. It's disrespectful to me as a Nigerian. Don't you dare say that. You go to UK and say we are in UK. They won't say that. And when you say we are in Nigeria, we are Nigerians. No, we are not. That's why things have not changed, because we're enabling it. Number 2, collaborate. Don't come around thinking you know it or I know it. For me, this is the year of collaborations. I was in a meeting just now collaborating because you don't know everything. God didn't give you everything. Okay? I have 1 minute, a couple of seconds left. Number 3, be what you teach. It is enough that, oh yeah, I can teach it. What are you teaching if you're not being it? If you teach a parrot to say hello, the parrot can say hello. So that tells you a human and a parrot can talk. It's not about your talking. It's about your embodying what you are saying. You becoming the word, like Jesus is the word. God is not God because he speaks. God is God because he is what he speaks. So let's be what we are saying. And be the service we offer. That's what I've also said. Anyone can talk. Thank you so much for your time. Woo! I did it.
Oh, wow, 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 wow. Well done, Coach K. I knew I could rely on you on hitting it at exactly the time. Well done, ma'am. One thing I got from your presentation is that graphic representation of the difference between effective and efficient. Efficient, using little to bring out a lot of output. Without much ado, I'd like to go to our next speaker, and we will be bringing on Madam Eitayo, your team. Idris, we can see that you are raising your hand. Please, if you have any question or comments, kindly put them in the chat box and we will get to you. Thank you so much. All right, we're really at the end. We're close to the end. Close to the end. We just have, after Madam Eitayo, we just have Dr. Marino to speak with us. So please, 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 thank you for your patience. Just give us a few more minutes, on this. So, Madam Mrs. Eitayo Iotim is an organizational psychologist and a human resource management specialist and ICT project manager. Her career successes include building digital transformation systems for employees of some of the largest organizations in Nigeria, and managing key relationships for a global brand, SAP, at C-level. She is certified in ability and personality testing, project management, and life coaching. She also is a certified cognitive behavioral therapy practitioner. She is member of the Life Coaches Association of Nigeria and a graduate member of the British Psychological Society. Mrs. Aitaya has an MSc in Organizational Psychology from the University of Manchester, UK, and until recently served as Chief Operating Officer at Nigeria Internet Registration Association. She was the CCTLD Manager of .ng domains. She is the CEO of Whetstone Coaching, a one-stop shop for women's mental health, and Talent Urbanity Limited, which caters to the human resource development needs of organizations. This lovely afternoon, Eitayo will be speaking with us on addressing the gaps within the workforce. Ladies and gentlemen, please put your hands together wherever you are and welcome with me Eitayo Iotim. Please unmute. You can unmute yourself so that we can hear you, ma'am. Madam Iotim?
I'm so sorry. I was just saying I can't unmute. Please allow me unmute. And then it went off. Can everybody hear me?
Yes, we can.
Great. Okay. I'm going to share my slides again. And I'm going to pray and hope that Coach K has left some anointing for my being able to do this in 10 minutes. Let's go. Good afternoon, everyone. All protocols duly observed. It's amazing to be here. Thank you. I'm happy that I was here from the beginning and I've listened to everybody. God bless you all. Thank you. I hope that we will get results from this and that work will start. So I've been asked to talk about addressing the gaps within the workforce. I'm just going to try to put some of the things that I have seen at work, in these few slides. And I hope that that will help us in pushing the conversations that we're trying to have here forward. So the first thing that we need to recognize is that the Nigerian worker is unique anyway. Like, we are different. Nigerians are different, yes, but the Nigerian worker has a unique kind of difference, being that we are faced with peculiar challenges, the challenges that the Nigerian worker faces. And some of them, I just highlighted a few. The corruption that is so entrenched, like I'm happy that Coach K spoke with just before me, because the corruption is so entrenched, we don't see it anymore. It's so easy to say, I'm going to give you a note to somebody. There's the obsolete educational curriculum. For those of us who left here and went to do a master's or degree abroad, you get there and you find out just how archaic the curriculum is. You can't even use examples in class that work. So we're talking about the labor law when I was in my master's. And when they said, oh, Nigeria, any examples? I said, no, just pass, let it go. Then there's the idea of elevating certificates over knowledge, skills, or abilities. That has to change. We're recruiting people who don't necessarily have the skills or the skill sets for the offices that they're supposed to occupy, and so cannot be productive. I think that this entire conversation, my scheme is about productivity more than anything else. How can we help the mental health of the Nigerian workers so that they can be productive? What about the irregularities in hiring practices? We hire people more based on emotions than based on all the knowledge, skills, and abilities that we should use to hire. In the organizations that have allowed me in recent times to run proper assessment centers, they're usually surprised at the final outcome. It is hardly ever the person you think it is by what you see. Personalization of roles. So people hold offices and become the offices, or is it that the offices become them? I'm not sure, one or the other. But when they leave, the organization struggles to move on. That is not how it is in advanced countries or in international organizations for that matter. So the Nigerian worker is already unique because he or she, they are faced with a peculiar set of challenges. What about the challenges in the society? So you take the worker from these society, and I won't overflog this because a lot of people have talked about it, but let me just pull some of it. Terrible living conditions. Some of our workers, and I want to speak to those of us that have personal staff or drivers. If you go to where they live, you will not allow them drive you because you recognize that they don't sleep well, they don't rest well, they get home at midnight, they sleep till 4 a.m., they have to be in your house at 6 a.m. So the living conditions are hard. When you have to do programs and you have to really go into the community, you'll be shocked at what you find in your immediate community. I took a walk this morning and I walked a path that I hadn't walked before. And what I saw was shocking, not too far from where I live. Gender-related challenges. There's still, people talk about the table, the glass ceiling, I don't know, in Nigeria, I don't know what it is. I think it's a wooden plank that has, nails in it. But actually rising is so gender dependent that people make it sound, hiring managers, make it sound like they're doing a favor when they say, oh, we need 2 women. Well, you need 2 competent people first, and then you can start to talk about gender. There's a lot of post-traumatic stress disorder that we see in the society, in the environment. And this is impacting on the capacity of these people to do the work that they've been hired to do. So they bring all these things to work. We see cases where a member of staff has been abusing a substance and the organization has no idea. He comes in clean all the time until something happens, and there's a reason to run a test. And then they find that this person has been under the influence for only God knows how long. So these societal influences come into the workplace. And then we now have mental health specific workplace factors, non-existent or inadequate health and safety policies. Do you know what happens to employees when they are ill? How many organizations have health insurance for their staff? How many health insurance packages talk about mental health? How many of them have a counseling system that you can access because you have medical insurance? Do you know that there are not many? In my last organization, I had the responsibility while I was there to review medical insurance. And every company that came to present, I asked them, what is your plan for counseling, for insurance in terms of mental health? And it was all but non-existent. So we have to start having these conversations. We have to talk about working hours. Even with COVID, many organizations did not make their work more flexible. So you expect employees to sit in front of a system for 6, 7, 8, 9 hours. If they were in the office, they would have gone to the lunchroom. They would have probably gone, somewhere, had a conversation with somebody. There's a lot of mental health impact working from home. And we need to start to have those conversations about how COVID-19, the pandemic itself and all the problems that it has brought, but also the lockdowns and how they have affected people. We have real cases, statistics about how domestic violence numbers went up. They were already horrific for Nigeria, but now they've gone through the roof. And we still do not have systems in place to deal with workers who have gone through domestic. They can hardly talk about what they have been through. So how do we begin to address the gaps? The first thing we need to do is sanitize employment practices, put round pegs in round holes, square pegs in square holes, do proper assessments. Don't bring your cousin, your nephew, throw nepotism out of the window, and let's put people where they are capable of. Let's have proper performance management systems, performance measurement systems. Let's see how we can have improvement systems. So you're not just also throwing people out on the street, you're asking them what can they do? Where can they work? Where can they fit? You know, you're having conversations with them that make it obvious that you're concerned about their life, work-life balance, and not just the time, the 8-9 hours that they spend with you. We need to inspire a culture of connection in organizations. As it is, the dichotomy is wide. So there's one person who actually earns better than everybody, who gets chauffeured around, who doesn't have any idea what their employees go through most of the time. And even if they have an idea, they really, we say, put yourself in another person's shoes, but many of us, and I say that even about myself, and I work with organizations in all strata, even about myself, that you become very disconnected sometimes from the case of the common man just because you don't see it. Not necessarily because you're not a kind person, but you're really cut off from it. So a lot of organizations are cut off. There's not enough employee engagement down the strata. So you do not really know what people are going through. Then they shut down. Then they do something happens, and then everything starts to unravel from there. Before this unraveling happens, it is essential that organizations start to build a culture of connection. I do emphasize relationships at work when I work with organizations. Then we need to encourage employee assistance programs. These programs hardly exist. They exist in very few organizations in Nigeria. And even in those organizations, they are right at the bottom when it comes to allocating funds for employee assistance programs, for having in-house counseling. And I mean, it is as easy as to take an employee who already has a tendency to be a mentor and taking them through counseling certifications so that they can provide that first line support. I picked somebody up one day who had lost a baby and had requested for a month away. And her company told her, no, all that is there for, for bereavement leave is 2 weeks. And so it was past the 2 weeks. This was her first day back at work, and she cried all the way to the office. And I was thinking, well, it's not one size fits all. There should be an assessment whether this person is ready to come back to work, or whether the person can work from home, or the organization can make some other arrangement to help the person. Then we need to initiate comprehensive medical insurance, which provides access to mental health services. It's not just about everybody today has spoken about mental health. It's important, it is key, it can impact on productivity, it can impact on us as a nation. Only God knows how bad it is. Only God knows how bad it is.
Yeah, you have 1 minute more.
Thank you, I'm almost done. Only God knows how bad it is. And then we now have medical insurance, which is there on paper, but doesn't provide access to mental health services. So they cannot walk into a clinic and ask for help. Because of that, we now have clinics who do not have connections with psychiatrists, psychologists. They don't have any in-house provision for mental health. That really, really has to change. And at some point, we're going to have to bring these conversations, put them in succinct modes, and put them before the decision makers in organizations. Otherwise, we will lose an entire workforce. God forbid that should happen. Thank you very much. Thank you. Thank you.
A big amen to that prayer, Tayo. Thank you so very much for that presentation. Just like the comment that Dove, the mentalist, raised, about awareness in the workplace, we really need to start making issues of behavioral and mental health policies in our organizations. Without much ado, I'd like to bring on the very next speaker. She needs no introduction. She needs no introduction. You've been hearing all the way of this program. I'd like to bring on Professor Akidotu Merino.
All right, thank you, everyone. Maybe you want to spotlight me there. All right, there you go. Wow, it's been awesome. Absolutely amazing. And I want to thank everyone who has participated in this symposium to shed light on mental health issues, dynamics, structures, and even our limitations in Nigeria. And so there's been so much that has been said from a variety of people. The whole goal, the whole point of this is that we can come together, hear what everyone is doing within their spaces, and at the same time be able to come back tomorrow with the ones who are interested in formulating a plan to move forward. So I'm going to share my screen with you, and I just have a few things to highlight and to punctuate, and I hope that I'll just be with you in a few minutes, and then we'll round this baby up and go home and go eat, do whatever we need to do. Actually, I guess we're home. Some of you might be at work. And so let's look at this presentation, and hopefully I can do justice to it within the time that's allotted to me. Okay, where is my slideshow? Okay, here we go. From current slide. All right. The facts are with us. They are indisputable, and the facts have been totally highlighted, punctuated today. There can be no health or sustainable development without mental health. I always say that mental health is a family's health, mental health is a community's health, and mental health is our nation's wealth. Mental health, as we know, is 3% in Nigeria, is 3.3% of the budget, and 90% of that goes to psychiatric hospitals. I don't know what happens to the other 10%, but I'm sure that somebody here can elucidate me tomorrow. But we understand, if you don't understand that mental health has a direct correlation with the economy, with the wealth of this country, then this number would do it for you. In Nigeria, annually, every year, we lose 21.6 billion naira annually because of mental health issues. That has to do with people who don't come to work because they call off. That has to do with turnover rates. That has to do with who are at work and cannot perform their optimal best because they have health issues. We don't call them, they have all those kind of physiological symptoms that we sometimes don't call it mental health. However, we know that mental health has a direct high correlation to an industry's performance. Employees who come to work with optimal mental health do better. And so this is something that is draining our economy, and we must address it. There should be no organization out there who is not looking at the mental health of their employees, because there's been studies and studies and studies that highlight that employees who are happy, employees who are well, they're more creative, they collaborate more, and they do better. And the bottom line is you make more money when you have those type of employees. I'll read every single thing on here because it's been addressed several times. What I want to talk about today is innovation. Innovation. Everything that has been said is fantastic. For us to move forward, however, we must be innovative. We have to think outside of the box. Innovation is a new way of doing things. We have to replace what's happening with something different so that we can get new results. If we keep moving the same trajectory in which we're moving right now, Nigeria is going to find it hard to close the mental health gap that is over 100 years old. We need to close that gap because if we want to be a part of the world of nations who is actually committing and contributing to the good of humanity as a nation. You're going to hear, I live in California, and you're going to hear in the United States, the highest, the most well-trained individuals are Nigerians. we earn more money. It is all across the spectrum in most developed countries. Why is that? Because when you take somebody out of an environment sometimes that is so restrictive, and you allow them to flourish and blossom, then they do better. Which is one of the reasons why this important symposium is so vital to the health of our nations. So innovative, we have to think differently. We have to think of ways of assessment, the ways of collaborations. We have to look at what our outputs are. We have to share information. So how are we going to do that? Whatever we do in this moment has to be bold. It has to be dramatic, and it has to have lasting change. We cannot depend on the government anymore. We want the government to lead. We hope that they lead. I personally hope they kick out that archaic what's that law? The criminal code, 327 code that incriminates people who have suicidal ideation. Lunacy code, I think it's called. So we need to get that away from our books and begin to pass this new 2020 policy that needs to be passed. We need to make sure that's done. So anyway, whatever is done has to be lasting, it has to be dramatic, it has to be sustainable. So we must think outside the box. Why did we decide to bring these people together? One of the reasons we decided to bring everyone together is because everybody needs to understand that in our own silos, we're all doing our own things. But when you go apply for this grant, when you go apply for grants at the USAID, or any international grants for that matter, one of the things they're going to ask you is, what is on ground? Who are the people collaborating? We all need to work together. And they also ask you, what is your innovation? What is your solution? What are we bringing to the table? We know that there's an African country that had this whole friendship bench, where they actually train grandmothers to give hugs and to talk to people about mental health training. There are countries who do a testimonial therapy, where they bring everybody who has been abused and anybody who has been sexually molested in some kind of way, and the community acknowledges this trauma and heal the trauma together. Because anytime there's a mental health abuse, it is a social justice abuse. And so there's all kinds of innovations out there. So in Nigeria, we need to bring ours to bear. All the things that we've said are excellent, but what can we do differently and without depending on anybody to pass anything before we do it? So that's one of the things that we want to punctuate. So we have to bridge the gap. We've all identified needs. Some of us have proffered solutions. We need to bridge this gap. This is the calling for all of us. Either you're a coach, either you are where did I put that? Hold on, I have the list of all the people. Yeah, either you are a medical doctor, a psychiatrist, a psychologist, a counselor, a social worker, a coach, a community member, faith leaders, educators, business people, NGOs, we're all in this together. There is no way out of this mental health conundrum that we have actually abdicated for so long, starting with the colonial masters. They did not allow us to even focus on this. And so now we have to take Nigeria back. And we're not just going to take Nigeria back based on our spiritual platforms. We're not just going to take it back based on our financial platforms. We're not just going to take it back based on political platforms. Mental health is a nation's wealth. Mental health is a nation's health. So if we are not healthy as a nation, emotionally, in our wellness abilities, then we cannot take our place, and we will not be able to build a sustainable country, nation for our children. This is why we're doing this. For me, this is how I define mental health, and this is why I tell my students, out, like my clinicians and anywhere that I go to speak. Mental wellness, this is what it is. It is that you're emotionally stable. It is that you're psychologically well. It is that you're socially connected. It is that you're financially able to sustain yourself. It is that you're spiritually connected to a higher power. And it goes on and on and on. You're relationally, that you have intimacy. That is what mental wellness is about. So when you hear us talk about mental health, don't think it's about some demonic or something that is far-fetched, like everybody has said today. It is about the future of our nation. It is about the future of our people. And I'm going to stop there because I know tomorrow we're going to come together and say these are the innovations that we're going to discuss, and this is how we want to go forward. Everybody has to be a part of this team. Everybody, the psychologists, everybody that I put on here. Interdisciplinary teams have to start functioning. Every one of us, we need to train so that people know what they're talking about. I want to say thank you to everyone who has participated. I know that all these questions that were brought forward today, I'm sure that we've answered most of them during the multiple conversations that we've had today. From the commissioners to everyone to the coaches, to the psychologists, to the psychiatrists, to the educators, to everyone who has presented, I want to say hearty thank you. And one more thing, I just want to say this before I leave, is that this is not somebody's baby. This is not one person's baby. This does not belong to me or my team at all. This is for all of us. I don't even care whose name is on it, as long as we do it right. There is a structure, there is a process that we're going to formulate tomorrow, and I sure hope that you come and be a part of it. It is not going to be 3-4 hours long, I promise you. I think tomorrow will be at 2 hours max, and we should be done. And at the end of that, we will have an action plan. Here's what we're going to do. This is how we're going to move forward, and I look forward to seeing you. Thank you very much.
Thank you so much. Thank you so much, Dr. Marino. Thank you. And for those of us who are a part of her team, we can let you all know that she practices what she preaches. I can tell you very much so. So tomorrow we are here again. It's the same link. And like Dr. Marino has shared with us, it's all about just coming up with a structure, moving this forward. It's all about starting an interdisciplinary team that would actually bring and concretize all the conversations that we have had on here. And it will be by 10 a.m. Saturday. Okay, so 10 a.m. we would like to start early this time around so that we can finish and, everyone will be released up for lunch since we're going to be here for just 2 hours. Okay, so thank you once again. Thank you. We cannot thank you enough. It's been a wonderful time. On behalf of myself, on behalf of Dr. Marino, the entire team right here, African Mental Health Alliance, on behalf of each and every association and ministry represented here, we would like to say a big and a huge thank you.
All right, thank you so much. All right, so music, everybody, au revoir, au revoir, thank you, odaro.
Look forward to seeing you all tomorrow.
Let's say it in all the languages.
Odaro.
Thank you.
Say the
Thank you. Thank you. Great speaker, great talk.